welcome on the behalf of PHYSIOLOGY online classes. I welcomes you all. Today we are going to discuss diabetes, and as you know, diabetes is very common disease we see in day-to-day practice. In this lecture we are going to discuss A to Z of the diabetes. So right from the definition to the pathogenesis, clinical features, also the diagnosis, treatment of the diabetes, complications of the diabetes, and also we are going to see the management of the complications also. So at the end of the lecture you will find that you know everything about the diabetes. Well, this lecture is lengthy because we have covered each and every aspect of the diabetes, but in the end you will find that whatever the time you have spent with the lecture, it is been quite benefited in the end. So go till the end, and you will definitely, I know that you will enjoy this lecture. This lecture is not only important for the student, so UG student, PG student, but also teachers we are aiming at. They will get lots of what we call this new concept regarding this disease, also a few new concept regarding the treatment part. They will also definitely will enjoy this lecture, and also these consultants, general practitioner, each and everybody will be benefited with this lecture, and I request you all to see hear this lecture till the end, and you are definitely going to get benefited with that. Before we could start with this lecture. This is some general information regarding this worldwide data regarding the diabetes, and in 2024 we have a figure that 589 million people they are suffering from the diabetes. This is the current data, and projected data till 2030 almost 643 million people they are going to affected with the diabetes. As far as the undiagnosed cases is concerned, 45 patient, roughly 45% of the patient remains undiagnosed. So this data is quite huge. Undiagnosed patient, 45% of the patient remains undiagnosed with the diabetes. And as far as this treatment gap is concerned, treatment gap in the sense what? Those patients who have detected to diabetes, treatment is started, but at some time they stops the treatment. So more than half the patient, it is considered that or said that they stop the treatment. So the important thing of regarding this data, if you consider, is there is a less awareness in the society regarding this disease, and awareness, we needs to increase the awareness. So when patient comes to us with a diabetes, and when we start a treatment or when we diagnose this disease, at that time only we should inform the patient that this disease will be there for the lifetime, and in that sense you needs to treat these take the treatment till the end there, isn't that? So this thing is very, very important, that at the beginning only you should explain the patient regarding all these things there. Okay, then we will start with the definition there first of all, and then we'll point wise we'll go ahead with the disease. So first of all, the definition, I have just highlighted certain points in the definition. So diabetes is a chronic disease. Everybody knows diabetic is a chronic disease and it is a metabolic disease. Okay. So it is a metabolic disease, it is a chronic disease, and what is there in the diabetes, what is the highlighted point in the diabetes, that elevated levels of the blood sugar. In the diabetes we have elevated levels of the blood sugar. So the basic core of the disease is what? The blood sugar levels are elevated, isn't that? So chronic disease, metabolic disease, and in this disease we have elevated blood sugar levels there. And because the blood sugars level are elevated, because it is a chronic elevated blood sugar levels, because it is a metabolic disease, these chronic elevated blood sugar levels, they impact heart, they impact kidney, they impact nerves, they impact blood vessels, and they impact eyes also, isn't that? So when I say they impact the heart, what we have, because of the atherosclerosis process there, these blood vessels they gets blocked there, the blockages are there, and because of the atherosclerosis, not only in the heart but also in the brain or brain vessels also, this atherosclerosis process it develops blockages there, and because of that this when the heart vessels are blocked, we get stable angina, maybe unstable angina, maybe myocardial infarction. When the brain vessels are blocked, we may have a stroke there, isn't that? So this could be there because of this atherosclerosis process. As far as eyes are concerned, we know this chronic diabetes, they develops what? Diabetic retinopathy. Okay. So we are going to see later on in the lecture what is that. Then when it affects the kidney, what we have? Diabetic nephropathy. Okay, we get a diabetic nephropathy, and when the blood vessels are involved, we get a peripheral vascular diseases there, and as far as nerves are concerned, we get a diabetic neuropathy. Okay, so each and everything whatever I have just mentioned, we are going to see later on in the lecture, but for the moment, as a part of the definition, it is a chronic disease, it is a metabolic disease, and in this disease what is the characteristic? Blood sugar levels are raised, and these raised blood sugar level, they impacts heart, they impacts eyes, kidneys, blood vessels, and nerves there. So as we know that this diabetes, it has got two major types there, type 1 and type 2, each of I think almost all of you knows this. So type 1 diabetes, what is this? What is that type 1 diabetes? It is a juvenile diabetes. Okay, so this diabetes we get in children. It is a juvenile diabetes, we call as a juvenile diabetes, and this diabetes we get in the children. And here definition wise, if you see what I have said, insulin is absent because insulin is secreted by beta cells of the pancreas, but the beta cells are destroyed. So here, because the beta cells of the pancreas which secretes insulin, they are destroyed, insulin is absent, insulin is not produced in the body. So the question is, why these beta cells are destroyed? These beta cells are destroyed by the autoimmune process. These beta cells are destroyed by what? Autoimmune process. And in this autoimmune process, what happens? In this autoimmune process, cytotoxic T cells, they destroys these pancreatic beta cell. So this is the autoimmune process, it is an autoimmune disease, and in this autoimmune disease, what we call as a T cell mediated autoimmunity. It is a T cell mediated autoimmunity. It cause the destruction of the pancreatic beta cells. This T cell mediated autoimmunity, it cause the destruction of the pancreatic beta cell. And also the autoantibodies, they also cause the destruction of the pancreatic beta cell. Now this pancreatic beta cell destruction by the T cell mediated autoimmunity, it cause bulk of the pancreatic destruction. So initiation of the pancreatic beta cell destruction, initiation of the pancreatic beta cell destruction is done by T cell mediated autoimmunity, and also bulk of the pancreatic beta cell destruction is done by T cell mediated autoimmunity. And later on in the disease, autoantibodies are also formed, and they also cause the destruction of the pancreatic beta cells there. Okay, so the point is initiation of the pancreatic beta cell destruction and bulk of the pancreatic beta cell destruction is done by T cell mediated autoimmunity, and these autoantibodies also cause a beta cell destruction, but they cause very what we call as a very small amount of a beta cell destruction, I will say. And this process of autoantibody related beta cell destruction, it occurs a little bit later on. So first of all, it is a T cell mediated autoimmunity, isn't that? Then this process, the process of this pancreatic beta cell destruction, these pancreatic beta cells, what they secrete? They secrete insulin, and these insulin producing beta cells, they are getting destroyed by this T cell mediated autoimmunity and the autoantibodies. This destruction process is a chronic one. Chronic in the sense what? It is going for a long period. It is not that in a single days or in a single month whole this destruction takes place. It takes lots of time for this autoimmune process to destroy these pancreatic beta cells. When I say it takes a long time for the beta cell destruction, it could be a months, it could be year or years, or it could be a decade also. It could be a decades also. Okay. So suppose anybody has started the beta cell destruction in the these autoimmune T cells are formed, and these T cells, they start the destruction of the pancreatic beta cell, suppose today. Then gradually the process of destruction will continue, and it may take 3, 4, 5 years or even 7 years, 8 years, maybe 9 or 10 years right from today for the onset of the diabetes there. Okay. So the process is quite a lengthy, it is a slow destruction. My point is the destruction of the pancreatic beta cell is very slow, and this process may last a month, may last years, may last a decade also. Okay. So this is the thing. So from the onset of the disease to the occurrence of the symptom, from the onset, so the destruction suppose started today, and the occurrence of the disease, the occurrence of the symptom, it will take a long time there. It will take a long time, and that period could be even a decade. Now here we have to note one important point, that unless there is a destruction of more than 50% pancreatic beta cell, the patient may not be asymptomatic. Okay. So the patient in other words we can say the patient becomes symptomatic once the beta cell destruction exceed more than 50%. Okay. So we do not get the symptoms unless the beta almost half the beta cells are destroyed, or more than half we can say. Okay. So once the beta cell destruction is started, once the beta cell destruction is started, uh, gradually once over the period it reach to the 50% mark or more than that, then only we get symptoms of the diabetes there. Sorry. So here I have what I have said, 50 more than 50% destruction, then a 60% destruction, gradually it may reach a 70% destruction, like that. So the point is, once once we are reaching to this 50 in between 50 to 60 mark, the patient may start getting symptoms of the diabetes there. Now suppose because of the symptoms we diagnose this patient here in between 50 to 60. Even after diagnosis, the process of destruction will continue. We have no way we can stop the process of the destruction there. So the process of the destruction of the pancreatic beta cell, it will continue even after the diagnosis. Okay, even after the diagnosis, the process of a destruction will continue. So this has been a very important point. It is not that we have diagnosed the patient, we have put the patient on the insulin, and the process of this insulin pancreatic beta cell destruction has stopped. It will not like that. Even if you have diagnosed the patient at the very early stage, at say 50 to 60, where there is a initiation of the symptom, the process of the destruction of the pancreatic beta cell will continue even after the diagnosis, isn't that? So you may it may be required to increase the dose of the insulin once the process of the destruction is going to continue over the period. You may require to increase the dose of the insulin. That's the important point there. So this is regarding this type 1 diabetes there. So here we have another slide there. So most common occurrence is in between 4 to 7 years of age. Okay, so these two age groups what I have mentioned, that 4 to 7 years and 10 to 14 years, these are the age group you can commonly see this type 1 diabetes. Okay, so the diagnosis of the type 1 diabetes usually occurs from 4 to 7 years and 10 to 14 years. These two age groups, maximum time of the patient, we diagnose this patient at these two age group. So it may occur at 10 years, it may occur before 4 years also, it may occur at after 14 also. Okay, all these patients, they can have at any age they can develop this, but these two age groups are the most common age group as far as a type 1 DM is concerned, and it may continue up to late 20. Okay, so from the beginning of the beta cell destruction to the occurrence of the clinical symptoms, it takes a few months or even years or even decade also. I have cleared that in the beginning only. Now here we have one slide there. If you see this slide, in this slide, if you see, this is been a normal islet here. This is the normal islet of a Langerhans, and in this normal islets, these are the pancreatic beta cells there. These are the pancreatic, is blue colored. These are the pancreatic beta cells there, and when the patient develops type 1 diabetes, these pancreatic beta cells get destroyed. So here these are the destroyed pancreatic beta cells there. Okay, you can see here. So this is the normal islet here. and this is the type 1 diabetes islet here, and you can see the difference there. Then we will go for the next type, that is a type 2 DM. This type 2 DM we call as a maturity onset diabetes, and there are two very important things with this type 2 DM. What are those two things? One is insulin resistance. What is insulin resistance? That is the body's inability to effectively use insulin. Insulin is there, but our body is not able to use that. Our cells are not able to use that. And what is second thing? Insufficient pancreatic insulin production. So these pancreatic beta cells, they are they are producing the insulin in a insufficient amount there. So these are the two things which are concerned with diabetes type 2. So in a type 2 DM, this insulin resistance means insulin is present, but our cells are not able to use that insulin. So this insulin resistance produces lots of strain on the pancreatic beta cells, and these pancreatic beta cells, because they have to do a lots of work there, excessive work there, they get exhausted, and in the end they undergo apoptosis. In the end, this pancreatic beta cell, because of this overwork, they get destroyed, and that result in insufficient insulin production. So the disease start with what? Insulin resistance. So insulin resistance is the first stage in a type 2 DM, and this insulin resistant ultimately cause insufficient pancreatic beta cell insulin production there. Okay. So the process in a type 2 DM starts with insulin resistance, and it is this insulin resistance which cause destruction of the pancreatic beta cell, because these pancreatic beta cells, they needs to work very hard, they produce more and more insulin, and in the end they get exhausted, and that causes the destruction of the pancreatic beta cell. In the end they undergoes apoptosis, and we get a disease, diabetes. Okay. So we are going to see the details of this insulin resistance. We are going to see the details of this pancreatic beta cells and how the disease is called. Each and everything we are going to see in the pathogenesis there. It comprises 90% of the cases of the DM. So this type 1 diabetes is occurring in almost 10%. So in whole this diabetes patients, 10% contribution is given by type 1, and this type 2 DM is contributing 90% there. Okay, and this being a non-insulin dependent. So type 1 diabetes we called as a insulin dependent diabetes, and type 2 diabetes is a non-insulin dependent diabetes. So here this type 1, it is contributing almost 10% of the cases, and it is also called as a insulin dependent diabetes mellitus, IDDM. Why? Because insulin is not produced. Why? Because the pancreatic beta cells are destroyed. Why they are destroyed? They are destroyed by the T lymphocytes, autoreactive T lymphocytes, and by the autoantibodies. And because these pancreatic beta cells are destroyed gradually over the period, the insulin no longer can be produced. Once the destruction process is over, total lack of the insulin in the body, and the body totally depends upon the insulin that is given from the outside. So you have to start the insulin in a type 1 diabetes, because insulin is not produced in the body. Okay, and therefore the therefore the patient of a type 1 is totally dependent upon external insulin. You have to give the injection of the insulin there, which we use subcutaneously, and in acute cases we may have to give intravenously. So this diabetes, in a type 1 diabetes, the main drug is a insulin there, and in a type 2 diabetes, what we call it is a non-insulin dependent, because here what happens, because of this insulin resistance, insulin is there but there is a resistance to the insulin there, insulin dependent diabetes mellitus. Okay, so in this type 2 DM we can use insulin as well as a OHD also, depending upon the patient condition, but in type 1 DM they almost always need insulin there, there is no other option. Then we will see some information regarding the pancreas. Why? Because pancreas is the very important organ as far as diabetes is concerned, because these pancreatic beta cells, they are the cells which secretes insulin there. Therefore, we should have some basic information regarding the pancreas there. So we know that this pancreas anatomically is a single organ, but histologically and functionally, it has got two different parts there, we know. And what are those two parts? Exocrine part, which secretes enzymes there, and the endocrine part, which secretes hormones. So exocrine parts which secretes what? Digestive enzymes, whereas this endocrine part, it secretes hormones. So we are concerned with the hormones because we are trying to learn diabetes here. We are concerned with the hormone part only. Now this endocrine part of the pancreas is in the form of a cluster of the cell called islets of Langerhans. Okay. So in the pancreas we have islets of Langerhans, and there are clusters of the islets of the Langerhans we get in the pancreas. So if you see here in this image, these cells which are in a green color, they are the exocrine cells or exocrine glands we can say, and these white bluish structures which are here, all these structures, they are the endocrine cells there. Okay. So these exocrine cells or exocrine glands, they are connected with a pancreatic duct. So they secretes these gastric enzymes into the pancreatic duct, whereas these endocrine cells, what they do? They secretes hormones. These endocrine cells, they secretes hormones and they directly get mixed with the blood. Okay. So these endocrine cells which they secretes hormones, all these hormones, they get directly mixed with the blood, and these exocrine glands, they secrete digestive enzymes. They get secreted into through these small ductules, they enters into the pancreatic duct, and ultimately through the common bile duct it opens into second part of the duodenum. But it is not the part which we are concerned with. We are only concerned with the endocrine function of the pancreas here. So this endocrine structure, let us come to the point again here. These endocrine cells, they are there in the form of the clusters, and these clusters are called what? Islets of the Langerhans. So all these cells, they are, all these clusters you can see here, they are the clusters of what? Islets of the Langerhans. Here we have shown some clusters of islets of Langerhans, and almost say 10 to 20 sorry, not 1 to 2 million islets of Langerhans are present in the pancreas. Okay, almost 1 to 2 million islets of Langerhans are present in our pancreas. So these islet cells here, suppose if we take a single islet and if we just magnify it, so this is one islet we have done the magnification here, and this we have one islet. In a single islet we have 4 types of cells are present. In a single pancreatic islets we have a 4 type of a cell. In a single pancreatic islet we have a 4 type of cell, which are those: alpha cell, beta cell, D cell or a delta cell, and the F cell. Okay, and each and every cell they secretes different hormones. These alpha cells they secretes glucagon. We are going to see details later on, but for the moment we just remember these alpha cells they secretes glucagon. These beta cells, what they do? They secretes insulin. Okay, so beta cells are very important. These beta cells they secretes insulin, while these delta cells or D cells they secretes somatostatin, while these F cells they secretes pancreatic polypeptide. Now these alpha cells, beta cells and delta cells, these 3 cells they are having a pure endocrine function, and F cells, even it has got endocrine function, but also it has got a exocrine function there. So these F cells they are mixed one, they are exocrine as well as endocrine, but these alpha cells, beta cells and the delta cells they are the purely endocrine effects there. Here we have another slide there. You can see this slide. These are the digestive enzymes produced by the pancreas: amylase, lipase, protease, and these are the, on this side we have hormones produced by the pancreas. Here also the same thing is there. This alpha cells, glucagon, beta cells, insulin, delta cells, somatostatin, and the pancreatic polypeptide cells. It is secreting pancreatic polypeptide. So see, what are the normal blood glucose level? Normal blood glucose level during the fasting is 60 to 100 milligram per deciliter of the blood. And when we are talking of a postprandial blood glucose, it should be less than 140 milligram per deciliter of the blood. So during the fasting 60 to 100 milligram, and during the PP or after food it should be less than 140 milligram. When the blood glucose level is high, okay, so once we take the food, the blood glucose levels will definitely increase. So when the blood glucose levels are high, insulin is getting secreted, and this insulin it will take the glucose from the blood. So there will be uptake of the glucose from the cell, or this glucose will enter into the cell with the help of the insulin, and that will control these blood sugar levels. We are going to see all this mechanism later on. And when the blood glucose levels are less, so suppose if we are not taking any food for say 2 hours, 3 hours, 4 hours, like that, our blood glucose levels will be dropped. So in that situation, glucagon will secrete it. It will cause the secretion of the glucagon by what? Pancreatic alpha cell. So pancreatic alpha cell they secretes a glucagon, and what this glucagon do? This glucagon it breaks the glycogen. Where this glycogen is present? This glycogen is present in the liver. This glycogen is also present in the muscles there. So these are the energy storehouse there, and we have a glycogen there. So this glycogen will be broken down, and it will release a glucose molecule, and this glucose molecule it takes into the this glucose molecule, it will enter into the blood there, isn't that? So this liver, the glycogen which is present in the liver, this glycogen, it is which is present in the liver, it is been broken down into the glucose there, and it is providing us the energy during the fasting time, or it is providing this energy for the formation of the ATP molecules. Now here the glycogen which is present in the liver, we are getting definitely a glucose from it, but the glycogen which is present in the muscle, even though it is broken down into the glucose, this glucose is not going to enter into the blood. Why? Because these muscle cells they are deficient of the enzyme what we call as a glucose 6 phosphatases. Because glucose 6 phosphatases is not present in the muscles, only the glycogen which is formed in the which is broken down in the liver into the glucose, this glucose only can enter into the blood there. Okay, that's the point we should remember. Because of these two hormones, blood glucose level is maintained in between 60 to 100 all the times. If the insulin is absent or if present but not utilized, then that will cause increase in the blood glucose level and decrease in the cellular glucose. Okay, so the point is, if the insulin is absent, what will happen? The blood glucose levels will remain high. Blood glucose levels will remain high, because for the entry of the glucose molecule into the cell, it requires insulin. The insulin is not present, so the entry of the glucose molecule into the cell is not possible, and it will cause raised blood sugar level. And second point is what? There can be a situation as in a type 2DM, what we have, there is a insulin resistance there, insulin is present there, but our body is not able to use, or our cells are not able to use this insulin. Why? Because there is a resistance to the insulin. Okay, because of the resistance to the insulin, these glucose levels are getting raised there. We are going to see this point in a pathogenesis, okay, later on. So cell is starving for the glucose even though plenty of the glucose is present in the blood. So in this situation, there is a lots of glucose in the blood, but still the cell is starving. Cell is starving for the energy, cell is starving for the glucose, even though a plenty of glucose is present in the blood. So this is the situation we have there in the diabetes. So there is a plenty of the glucose there in the body, there is a plenty of the glucose there in the extracellular space there, but still the cells are starving for the glucose because the hormone which is required for the entry of the glucose molecule in the cell is absent, or it is present, but there, because of the resistance, because of the insulin resistance, it is not working there. Okay, so in a diabetes, we have two types we have seen. Which two types? Type 1DM, type 2DM. Also we have seen some primary informations regarding the pancreas, isn't that? How these alpha cells they secretes glucagon, how these beta cells they secretes insulin, then delta cells they secretes somatostatin. Okay, so these primary informations we have. Also we have seen some normal blood sugar levels there. What are the normal sugar levels we are expecting? How this insulin and glucagon they maintains the balance between the blood sugar. Now we are going to see the further details, what will happen with the low blood glucose and what happens with the high blood glucose. So when the blood glucose levels are low, it will stimulate the pancreas to secrete what? Glucagon. Okay, so it will cause the secretion of the glucagon by which cells? Pancreatic alpha cells. And what they will do? They will break down the glycogen which is stored in the liver, and it will release a glucose into the blood. Okay, and it will cause the blood sugar level to be at the normal level. When there are the high blood glucose levels are there, it will stimulate the pancreas to secrete the beta cells, and these beta cells, when they secrete the insulin, it will take the glucose into the cell, and that will cause to achieve the normal blood glucose level. So this is what the whatever we have just tried to say here in this slide. Here we have seen in the image. Take a food, these blood glucose levels are raised and it causes the secretion of the insulin. Now we are going to see the mechanism how insulin is being secreted. Now before that we should also see how these incretins, what we call as a GLP-1 and the GIP, are secreted, because these are the two hormones, GLP-1 and GIP. They stimulates the secretion of the insulin, or they exaggerate the secretion of the insulin. So first of all we will see how these incretins are secreted, and then we will see how the insulin and the mechanism of secretion of the insulin rather, and the mechanism of secretion of the glucagon. So now we are going to see the three things. First one is how these incretins are secreted. Then we are going to see how these insulin is secreted and glucagon is secreted one by one. We are going to see this secretion of the incretins, how these incretins have secreted, what is the mechanism there of the secretion of the incretin. And when we say incretins, means GLP-1 and the GIP, both the hormones we are considering. So until now what we know is insulin. When we take a food, when the blood sugar levels are raised, it is the insulin which is secreted by the pancreatic beta cell, which maintains the blood glucose levels. But this insulin secretion is stimulated by these incretins. So it is the incretin which secretes the secretion of the insulin. And before going to see actual mechanism of the insulin secretion, we must first see how these incretins are secreted, which are the boosters which are going to give a boosting to the secretion of the insulin, isn't it? So first we will see how these incretins are secreted. When we take a food, these cells, what we call as a enteroendocrine cells, they are present in the intestine, and these enteroendocrine cells they are of two types. One is a L cell and the second one is a K cell. So L type of enteroendocrine cell, it secretes GLP-1, this hormone it secretes, and the K type of enteroendocrine cells, it secretes GIP hormone. Now this GLP-1 and GIP, these two hormones, they have a effect on the insulin and the glucagon. Okay, so these two hormones, they have an effect on the pancreatic beta cells and the pancreatic alpha cells. What effect they have, we'll see here. But the point is, when we take a food, what will happen? In this food, this glucose will be formed, and this glucose will be absorbed from what? Intestine. Okay, so intestinal cells they absorb this glucose, and this glucose is also being entered into these enteroendocrine cells because they are present in the wall of the intestine, internal lining there. Okay, so these enteroendocrine cells they absorb this glucose, and this glucose which enters into these cells, rather than absorb, we will say they enters into the cells. This glucose, what it does, it levels, it increases the ATP production in the cell, and ultimately this increase in the ATP production of these cells results in the secretion of the GLP-1 and GIP. Okay. So it is this glucose which enters into this enteroendocrine cell is responsible for the GLP-1 and the GIP. So here I have mentioned one thing. Let me just show you. Just I will take you to the nearer. So this secretion of this GLP-1 and GIP by the enteroendocrine cell depends upon the absorption of the glucose by the cell, that is nutrient glucose, not on the plasma concentration of the glucose. This has been a very important thing just we are trying to learn here, that these the secretion of these two hormones is entirely depend upon the nutrient glucose, that is the glucose they are absorbing. Okay, the secretion of the these two hormones GLP-1 and GIP is entirely dependent upon the nutrient glucose, not upon the plasma glucose, not upon the plasma glucose. Okay, so the glucose which is there in the intestine, when these glucose enters into the cell, they do the secretion of the hormones GLP-1 and the GIP. It has nothing to do with the concentration of the glucose in the plasma. This glucose dependent action is depend upon the nutrient glucose, not concerned with the plasma glucose, isn't that? So nutrient glucose not on the plasma concentration of the glucose, and that's why when we give intravenous infusion of the glucose does not stimulate the GLP and GIP secretion. Suppose if there is one patient there, okay, and in that patient if we give these intravenous glucose there, 25% dextrose say, or if we give DNS 5% or 10%, it is not going to cause secretion of the GLP-1 and the GIP because it is a plasma glucose. So increase in the plasma glucose concentration do not have any effect on the secretion of the GLP and GIP. It is not going to stimulate this enteroendocrine cell. Okay, so increase in the plasma glucose level is not going to increase the secretion of the GLP-1 and GIP. It is only the nutrient glucose, it is only the glucose that is being entering into these enteroendocrine cells from the intestine is going to cause the secretion of the GLP-1 and the GIP. That's been a very important aspect there. GLP-1 and GIP both of them have a effect on these pancreatic alpha cells and the beta cells. So let us see what are the effects of these GLP-1 and the GIP on the pancreatic beta cells. This GLP-1 it stimulates secretion of the insulin from the pancreatic beta cell. GLP-1 it stimulates suppresses the pancreatic alpha cells and therefore it decreases the glucagon. So see how these things are happening there, that when the GLP levels are increased, and what is the action of this GLP? This GLP-1 basically it stimulates the pancreatic beta cell to secrete insulin, and it suppresses the pancreatic alpha cells, and because of the suppression of the alpha cell, what happens? It decreases the secretion of glucagon. So the person has taken the food, because this food is taken, the glucose levels, the nutrient glucose in the intestine is raised, and it is been entering into the cells what we call enteroendocrine cells in the intestine, and these enteroendocrine cells in the intestine, when the glucose levels are raised, they get stimulated because they are glucose dependent. They get stimulated and they secretes what? They secretes incretins. Two types of incretins, GLP-1 and GIP. This GLP what it does? It stimulates the pancreatic beta cells. They start secreting insulin. It suppresses the pancreatic alpha cells. It starts the suppression of the hormone glucagon. So this food which is being taken is ultimately responsible for what? Increase in the insulin secretion and decrease in the glucagon secretion. That's what we want, isn't it? Now see what is happening with the GIP. This is the second hormone there. This GIP is also stimulating this pancreatic beta cell. This GIP is also stimulating the pancreatic beta cell, and that's why again it is causing the secretion of the insulin. Just like that, those GLP-1 hormone, this GIP is also causing the secretion of the insulin there. But as far as these pancreatic alpha cells are concerned, sorry, let me change that. As far as the secretion, as far as the pancreatic alpha cells are concerned, they stimulate this pancreatic alpha cell and they increases the secretion of the glucagon. They increases the secretion of the glucagon there. So this GLP-1 it is causing the stimulation of the pancreatic beta cell. This GIP-1 is also causing a stimulation of the pancreatic beta cell. So both these hormones they are increasing the secretion of the insulin. But as far as the glucagon is concerned, they have a opposite action. This GLP-1 is suppressing the secretion of the glucagon, and GIP it is stimulate the secretion of the glucagon. That's the difference between these two hormones as far as the action is concerned. Now there is one more thing we should know here, that is the DPP-4 enzymes. Okay, so these DPP-4 enzymes, what is the role of this DPP-4? Because you might have been heard DPP-4 inhibitor drugs. Okay, so these drugs they are depends upon this DPP-4 mechanism there. So DPP-4 are the enzymes, they are secreted by adipocytes, hepatocyte renal cells and pancreatic alpha cells and the beta cells. So DPP4 is the enzyme. This enzyme is secreted by which cells? It is secreted by adipocytes, it is secreted by hepatocytes, it is secreted by renal cells, it is secreted by pancreatic alpha and beta cells. So there are many cells there which secretes these DPP4 enzyme. What is the function of this DPP4 enzyme? It inhibits or it breaks down GLP-1 and a GIP. So the incretins, what we call GLP-1 and GIP, these incretins are metabolized or they are broken down by this enzyme DPP4, and this DPP4 is secreted by all these cells. Okay. So the important point is this GLP-1 and GIP, they have got a very short half-life, and they are broken down by these DPP4 enzyme, which is secreted by all these cells there. The membrane bound DPP4 is also known as CD26, forget about that. It has been additional information there. So DPP4 inhibitors inhibits DPP4. This increases the bioavailability of both GLP and the GIP. So the drugs what we have, DPP4 inhibitors. What these DPP4 inhibitors do? They inhibit this enzyme. Suppose DPP4 is inhibited, this DPP4 enzyme is inhibited, then what will happen? GLP and GIP, they will not be broken down. Okay, they will remain in the plasma, isn't that? If we inhibit this DPP4 enzyme, then this GLP-1 and GIP, they will remain in the plasma for a length of a time there, and that's what we call bioavailability. So increased bioavailability of these incretins there. So these DPP4 inhibitors, they inhibit this DPP4, and that causes increased bioavailability of GLP-1 and the GIP. Okay. So we are going to see these things later on, but for more, that will cause secretion of the insulin, that will cause the secretion of the insulin, or it will give boost to the secretion of the insulin, isn't that? And that's why we can control our blood sugar levels, okay, with the DPP4 inhibitors. Now we'll move to the next point. Now we'll see the mechanism of secretion of the insulin. So when we take a food, gradually the blood glucose levels are raised. So the plasma glucose levels are gradually raised. So these pancreatic beta cells, they are supposed to secrete the insulin when the plasma blood glucose levels are raised, and what happens, this glucose which is present in the plasma, when it is raised, this glucose molecule starts entering into the pancreatic beta cell. Over these pancreatic beta cells, there are two types of receptors are present. One is a GLUT1 receptors and a second one is a GLUT2 receptor for this glucose molecule. And through these GLUT1 and GLUT2 receptors, these glucose molecules, they start entering into the pancreatic beta cell. Gradually the concentration of the glucose in the pancreatic beta cell, it starts getting up and up, and that leads to increased glycolysis in the pancreatic beta cells. So this raised glucose, it initiates the increased glycolysis, and that ultimately leads to increase in the ATP production in the pancreatic beta cells. So see the sequence. So we have taken the food, plasma blood glucose levels are raised, that is causing entry of these glucose molecules into the pancreatic beta cells, and these pancreatic beta cells, what happens? Process of glycolysis, it starts in the pancreatic, process of glycolysis is increased in the pancreatic beta cells, and that leads to increase in the ATP production, and this increase in the ATP production leads to shutdown of the potassium channels. So the potassium channels which are present in this cell membrane, they shuts down when the ATP production is increased. So these potassium channels which shut down, they are ATP dependent, and because they are ATP dependent, increase in the ATP production cause closing of these potassium channels. Once these potassium channels are closed, what happens? This shutting down of these potassium channels leads to increase in the positive ions inside the cells, and that is leading to the depolarization of the cell. So cell is depolarized now, and once this beta cell is depolarized, it leads to opening of the voltage dependent sodium and calcium channels. So these sodium channels and the calcium channels, they opens up when the cell is depolarized. Okay. So once this sodium and potassium channel opens up, what will happen? It will start entry of the sodium ions. When this voltage gated sodium and the calcium channels, they opens up, what will happen? It cause the entry of the sodium and the calcium ions into the cell. So sodium and calcium ions are entering into the cell, and that causes insulin containing vesicles to move towards the cell membrane and fuse with the cell membrane, and ultimately cause exocytosis. Means what? They breaks up these vesicles, they breaks up and they release the insulin into the plasma. So if you see the sequence of events, again I will repeat what is happening. First we are taking the food, plasma blood glucose levels are raised. These raised plasma blood glucose levels, it initiates entry of the glucose molecule into the pancreatic beta cell. In the pancreatic beta cell, in the plasma in the cytoplasm, the level of the glucose molecule, it increases, that leads to increase in the glycolysis process in the beta cell, that is causing more number of ATP production in the pancreatic beta cell. It is leading to shutting down of the potassium channels. Because of that, the cell is depolarized, positive ions are retained, it is causing depolarization of the pancreatic beta cell. This depolarization of the pancreatic beta cell, now the electrical activity inside the pancreatic beta cell is raised, and this electrical activity is causing what? It is causing opening of the voltage dependent sodium and the calcium channels. These voltage dependent sodium and calcium channels, they are opened up. This opening up of the sodium and the calcium channels is causing what? It is causing two things. First of all, what is happening? See, insulin containing vesicles to move. It is causing the insulin containing vesicles to move where? Towards the membrane of the pancreatic beta cell. So insulin containing vehicle, they start moving towards the pancreatic beta cells here, and it causes translocation. It causes translocation of these vesicles, or we can say it causes fusion of these vesicles with the cell membrane. So this suppose this is been a insulin containing vesicles here, and these insulin containing vesicles they will start moving towards the cell membrane, and ultimately they will fuse here with the cell membrane, and they will cause, ultimately these vesicles will rupture and will cause release of the insulin into the plasma, So the process which is started with the food intake, ultimately it will cause release of the insulin. So these two terms, it is transportation and the translocation. Transportation of the insulin containing vesicles, and the translocation means fusion of the insulin containing vesicles with the cell membrane, and in the end exocytosis, release of the insulin containing vesicles. So these three processes they happens once these sodium and the calcium channels are opened. Sodium and the calcium ions they enters into the cells, and once they enters into the cells they cause these insulin containing vesicles to move towards the cell membrane of the pancreatic beta cell, fusion of these vesicles with the pancreatic beta cell membrane, and ultimately release of the insulin by the process of exocytosis. They are ruptured, these vesicles, and they release the insulin into the plasma or into the blood rather. Okay. So whole this process, if you see, then what is important, this whole the sequence of the events that is happening inside this pancreatic beta cell from the food intake up to the release of the insulin, we can just try to remember with the simplicity. Now here if you see this flow chart, there is no difficult stage as such. You can easily remember all these events. Other than this, there are a couple of things which are also very important in whole this process. Those also we'll see. Now this insulin secretion process is depends upon what? It depends upon the level of the glucose in the plasma. Okay. So when the plasma glucose levels are raised, then only it will cause secretion of the insulin. Why? Because when the plasma glucose levels are raised, then only the glucose molecules they start entering into the pancreatic beta cell, and then only it will cause secretion of the insulin by this whole mechanism. That means that this insulin secretion is a glucose dependent. This insulin secretion is a glucose dependent. Now just a few minutes back, what we have said, these incretins, that is a GLP-1 and GIP, these incretins, they do what? They stimulates the insulin secretion. They stimulate the process of insulin secretion. Now here what we have seen that this insulin is a glucose dependent, and raised blood glucose level is causing the secretion of the insulin. Then what is the exact role of a GLP-1 and GIP here? Once this process is a glucose dependent, then what is the exact role of this GLP-1 and the GIP? The exact role of GLP-1 and GIP is that these two hormones, GLP-1 and GIP, they does two things in this insulin secretion. How they help? Let us see how they helps in insulin secretion. So these two hormones, GLP-1 and GIP, they potentiates glucose dependent insulin secretion. So whatever the process we have seen here, this secretion of the insulin, whole this process is potentiated by this GLP-1 and GLP-2. Now these incretins, all GLP-1 and GLP-2, which are secreted, we have seen that they are secreted by endocrine cells. So these two hormones, they have got the receptor over these pancreatic beta cells. We have seen that. So these receptors which are present over these pancreatic beta cells for GLP-1 and the GIP, once these two hormones they combines with the receptor, these they cause potentiation of the glucose dependent insulin secretion. So this glucose dependent insulin secretion, whole this process is being potentiated or catalyzed by these two hormones. So that's what I have just mentioned here. Glucose dependent insulin secretion is catalyzed by GLP-1 and GIP, which involves transportation and translocation of the insulin vesicles. Okay. So these two hormones they helps in a transportation of the insulin vesicles and the translocation of the insulin vesicles. Means what? These two hormones they helps in the movement of these insulin vesicles towards the cell membrane. They also helps in what we call as a fusion of these insulin vesicles with the cell membranes, means translocation, and also the process of the exocytosis is also catalyzed or amplified by these two hormones. So whole the things, that means transportation, translocation, translocation and the exocytosis. All these processes which are important stages in the secretion of the insulin, they are catalyzed, they are amplified by these GLP-1 and GIP, means incretins are the hormones which catalyzes the process of transportation and translocation, which stimulates the transportation and translocation and also the exocytosis that ultimately leads to entry of this insulin into the blood there. Okay. So these two hormones GLP-1 and GIP, they have this role of a catalyzer in whole these process. This is one thing. Now one more thing is there. Let us come to this part. ATP production in the pancreatic beta cells is directly proportional to the concentration of the plasma glucose, and therefore increase in the plasma glucose results in more ATP production generation in the pancreatic beta cells. See the thing. So the entry of these glucose molecule inside these pancreatic beta cell depends upon what? Concentration of the glucose in the blood. So once the concentration of the blood glucose it is increased, it cause entry of this glucose molecule inside the pancreatic beta cell. So the ATP production in the pancreatic beta cell is directly proportional to concentration of the plasma glucose. So as the plasma glucose levels is raised, it start more and more glucose molecule to move inside this pancreatic beta cell, and that is causing more and more ATPs being produced, isn't that? So this process of ATP production and the amount of glucose in the plasma, they have got a direct proportionality. Okay, more the concentration of the plasma glucose, more is the ATP production. Why? Because more amount of glucose is entering into the cell when the glucose levels are high, causing increase in the ATP production. Okay. So therefore the increased plasma glucose results in a more ATP generation in the beta cells. And second thing is these potassium channels, they are ATP sensitive here. These pancreatic beta cells potassium channels, they are ATP sensitive. once these ATP levels are raised, these potassium channels, they are shut down because they are sensitive to these raised ATP levels there. An increase in the ATP causes a shutdown of the potassium channels. Okay. So, I hope that whole this mechanism just I have tried to simplify it as much as possible. Now we will see the mechanism of a glucagon secretion. So now we will see the mechanism of the secretion of the glucagon. So what is the function of the glucagon? Glucagon, it does glycogenolysis as well as gluconeogenesis. So when our body is deficient of the energy, the stored energy in the liver and in the muscles, it is utilized with the help of the glucagon, isn't it? So glucagon stimulates the process of glycogenolysis and gluconeogenesis. This gluconeogenesis takes place in the fat cells and glycogenolysis takes place in the liver and the muscles. So when did this glucagon is secreted? When the blood glucose levels are low, this glucagon is secreted, and we are going to see the mechanism of the secretion of the glucagon. But before we could see the mechanism of the secretion of the glucagon because of the low blood glucose level, we will first try to see the mechanism of suppression of the glucagon because of the high blood glucose level, and then we will move to the mechanism of the secretion of the glucagon due to low blood glucose level. So first we will see the mechanism of a mechanism of a suppression of the glucagon due to high blood glucose level. We know that when the blood glucose levels are high, suppression of the glucagon is reduced because we doesn't needs any energy. The blood glucose levels are high, we doesn't needs any energy, isn't that? So at that in that scenario, the glucagon is supposed to be suppressed. So first we will see the mechanism of the suppression of the glucagon. Basically, why we are trying to see that first? Because once we understand the mechanism of the suppression of the glucagon, it is bit easy to understand the mechanism of a secretion of the glucagon, isn't it? So first we will see the suppression of the glucagon. So here, if you see, this is a pancreatic alpha cell, and these blood glucose levels, they are high. Blood glucose levels are raised, isn't it? Blood glucose levels are raised, and because of these raised blood glucose levels, what will happen? Plenty of glucose molecules, they are entering into this pancreatic alpha cell. Okay, so all these G for glucose, all these glucose molecules, they are entering into this pancreatic alpha cells. So number of glucose molecule in the cytoplasm of these pancreatic alpha cells are more, and that will leads to what? That will leads to the increased ATP production. That will leads to the increased ATP production. So high plasma blood glucose level, that is leading to more number of glucose molecules entering into the pancreatic alpha cell. In the cytoplasm, we have plenty of glucose molecule, and these plenty of glucose molecule, they are causing more ATP generation. So number of ATP molecules are more. When these ATP molecules are more, what will happen? It will shut down these potassium channels. So these increased ATP molecules, they will cause closing of the potassium channels, and these closing of the potassium channels leads to the depolarization of the cell. So see here, these plasma glucose levels are raised, increased ATP production in the cell because more glucose molecules are entering into the pancreatic alpha cells, then that will cause the shutdown of the potassium channels. So more potassium they will retained inside the cell and that will cause depolarization of the cell. So positive ions are retained there, it will causing depolarization of the cell, and that results in closing of the sodium and calcium channel. It causes decreased electrical activity because what we know, these calcium channels when the calcium is entering into this pancreatic alpha cells, it is going to be a stimulant for the release of the glucagon. But his calcium channels they are closed because calcium is a triggering factor for the release of the glucagon, isn't that? And now because of the closing of this sodium and the calcium channels, no longer calcium can enter into the cell, and that results in a decreased electrical activity of the cell and it stops glucagon release. So glucagon release is stopped or no glucagon release is there from the cell. So if you see whole this sequence of the event and if you compare with the release of the insulin from the pancreatic beta cell, if you remember this depolarization of the cell as far as the pancreatic beta cell is concerned, we have seen that it is causing opening of the sodium and the calcium channels, but here the depolarization of the pancreatic alpha cell is causing closing of the sodium and the calcium channels. So here this depolarization of the pancreatic alpha cell is causing closing of the sodium and the calcium channel, whereas in case of a insulin release in a pancreatic beta cell, the closing of the potassium channel or depolarization of the cell is resulting in opening of the sodium and calcium channel. But here in case of a pancreatic alpha cell, the depolarization is causing closing of the sodium and calcium channel. And what we know is the calcium is very important for the release, there is a release of the insulin in case of a pancreatic beta cell and the release of the glucagon in case of a pancreatic alpha cell. Here because the calcium channels are closed now, there will be a decreased electrical activity in the cell and that stops the glucagon release. There will be no glucagon release. So this is how the suppression of the glucagon occurs in case of a raised blood glucose levels. Now we will move to the low blood glucose levels. What happens with the reduced blood glucose levels? Let us see here. So here the plasma glucose levels are less. Less plasma glucose means less entry of a glucose molecules inside the cell. Less entry of the glucose molecule inside the cell will result in a less ATP production in the cell, and this decreased ATP production in the cell, now very important one, this decreased ATP production in the cell, see this low activity of the low activity of the potassium channels results in a slow efflux potassium ions. So here when these ATP molecules are reduced, when because of this low glucose, when the ATP molecule production is reduced, low ATP production is there, that will cause slow release of the potassium ions, So see here, we have a less glucose here, so we have a low glucose here. This low glucose will cause decreased glucose concentration in the cytoplasm of the pancreatic alpha cell, and this decreased concentration of the glucose in the pancreatic alpha cell, that will results in a decreased ATP production, and this decreased ATP production is causing what? Slow efflux of the potassium ions. So potassium ions will gradually, very slowly starts moving outside the cell. Okay, so potassium ions, they will slowly start moving outside the cell. Okay, so they are moving outside the cell, potassium ions. So this slow release of the potassium ions from the cell is causing partial repolarization of the alpha cell. It is causing partial repolarization. Why? Because these positive ions are slowly released from the cell. Because these positive ions are slowly released from the cell, there will be decrease in the positivity inside the cell, isn't that? In other words, the negativity inside the cell will increase, or there will be a decrease of positivity inside the cell, and that will result in a partial repolarization of the cell. So because these positive ions are going outside of the cell, it is causing a partial repolarization of the cell. Now here this word is very, very important, that this potassium channels, they are slowly releasing these potassium ions. They are slowly releasing this potassium ion, and that is causing a partial repolarization. Because it is a slow release of the potassium ion, it is only causing a partial repolarization. So partial repolarization is very, very important factor, and this partial repolarization is responsible for the opening of the sodium and the calcium channels. Very important one. This partial repolarization, it is stimulating these sodium and calcium channels to open. It is causing the sodium and the calcium channels to open. So influx of the sodium and the calcium there. Influx of the sodium and the calcium. So it is causing influx of the sodium and the calcium, and it is resulting in once this sodium and the calcium channels are opened up, this calcium which is coming in, which is a triggering factor for this glucagon release, it is causing transportation of the glucagon vesicle to the cell membrane. So both the process what we have seen with the insulin, that is the transportation and the translocation. Transportation of the glucagon vesicles and translocation of the glucagon vesicles and exocytosis of the glucagon vesicles. All these events they occurs in the cell, and that ultimately leads to the glucagon release. So transportation of the glucagon vesicles and a translocation of the glucagon vesicles, and ultimately exocytosis of the glucagon vesicles, releasing the glucagon into the blood. So if you see whole this process, this calcium is a triggering factor for the release of the insulin, for the release of the glucagon, and even release of the incretins in the enteroendocrine cells. So whole the process is the same as far as these calcium ions are concerned. So this low blood glucose level ultimately leads to the glucagon release, and here this high plasma glucose level is causing the suppression of the glucagon. So this is the mechanism we should understand from the bottom of the heart as far as the secretion of the insulin is concerned and the secretion of the glucagon is concerned. To see the effect of low blood glucose levels and the high blood glucose levels in terms of the electrical activities inside the pancreatic beta cell and the alpha cell. So I have made 3 columns here. In this first column certain features I have mentioned, and in this second column the thing related the beta cell, and here the thing related with the alpha cell. So point number 1 here is what happens with the potassium channels when the blood glucose levels are low. When the blood glucose levels are low, what happens with the potassium channels? So we have just seen that when the blood glucose levels are low, the activity of the potassium channel is very high as far as the beta cells are concerned. So the potassium channels in the beta cells, they are highly active when the blood glucose levels are low. And what happens with the potassium channels of the alpha cells when the blood glucose levels are low? The activity of the potassium channels of the alpha cell is very low when the blood glucose levels are low. We have just seen. So when I say the activity of the potassium channels of the pancreatic beta cells when the blood glucose levels are low is high, means what? The activity of the potassium channels of the pancreatic beta cell is high when the blood glucose levels are low. Means what? See, we have just seen that these potassium channels they opens up when the blood glucose levels are low. So the potassium channels in the pancreatic beta cell they opens up when the blood glucose levels are low, and because they opens up, these potassium ions they are moving very fast outside the cell. So this we call as a high activity of the potassium channels. So why I have said here the potassium channel activity is high when the blood glucose levels are low. Why? Because the potassium ions they are moving up, the potassium channels are completely open up and the potassium ions are moving fast outside the cell, and this we refer to as a high activity. Now here I have written these pancreatic alpha cells are doing the low activity of the potassium channels. Means what? These we know that when the blood glucose levels are low, there is a partial opening of the potassium channels. So potassium channels they are partially opens up when blood glucose levels are low as far as these pancreatic alpha cells are concerned, isn't that? And because of that, these potassium ions they are slowly moving outside the cell. So partial opening of the potassium channel is causing slow movement of the potassium ions, and that we refer to as a very low activity of the potassium channel. So this is the difference. Then next is the resting membrane potential. The resting membrane potential is a minus 70 millivolts as far as beta cells are concerned, and that of the pancreatic alpha cell is a minus 55 millivolts. So if you see when these potassium channels they open up and these potassium ions they are moving outside the cell, they are causing increase in the negativity there, and the cell is hyperpolarized. Cell is a hyperpolarized. So there is this hyperpolarized, this term we use when the cell becomes more negative, and at this point cell is electrically silent. These cells are electrically silent. There is no electrical activity inside this cell, and here this partial repolarization occurs. Why? Because these potassium ions, they are slowly moving out. So because of slow movement of the potassium ions, cell is a partially negative, and that we called as a partial repolarization. Cell is become slightly negative because of the slow movement of this potassium ions, partial opening of the potassium channels, and this partial repolarization, as we have just learned, it is responsible for the opening up of the sodium and the calcium channels. This partial repolarization of the pancreatic alpha cell is responsible for what? This partial repolarization, it opens up voltage gated sodium and the calcium channels. And because these sodium and the calcium channels, they are open up, there is a rush of the ions, sodium ions and calcium ions inside the cell. The positive ions, they are moving inside the cell, sodium and calcium. And what is happening? They are causing the depolarization of the cell. They are causing the depolarization of the cell. Now, this calcium and this sodium ions which are moving inside the cell, what will happen to the threshold potential? Let us see here. This threshold potential here, it is a minus 60 millivolts, and here the threshold potential of the pancreatic alpha cell is a minus 42 millivolts. Now see here, the resting potential is how much? Minus 55 millivolts. When these voltage gated sodium channels will open, it will take this resting membrane potential from the minus 55 to minus 42 millivolts, because the sodium, they are positive charged ions, they are rushing inside the cell, and they will take this resting membrane potential from minus 55 to minus 42 millivolts. And also we have said that calcium ions, they are also coming inside the cell, and these calcium ions which are coming inside the cell, they will generate the action potential here. On this side, this RMP, resting membrane potential, is how much? Minus 70 millivolts. And when this calcium, when these potassium channels are closed, when the blood glucose levels are high, when the blood glucose levels are high, see here, when the blood glucose levels are high, what will cause potassium channels? They are closed, and this closing of the potassium channel, this closing of the potassium channel will do what? It will depolarize the cell membrane and initiating the electrical activity. Means what? When the potassium channels are closed, when the blood glucose levels are high, that will result in opening up of the sodium and the calcium channels in the pancreatic beta cell. And because it is causing opening up of the sodium and the calcium channels, what will happen? The sodium ions which are moving inside the cell, that will take this resting membrane potential from minus 70 to minus 60 millivolts, and these calcium ions, they will generate the action potential from here, isn't that? So effect of the depolarization, next point, effect of the depolarization on the stimulation, it stimulates the insulin secretion in the pancreatic beta cell, and here it inhibits the secretion, glucagon secretion. Now these high glucose levels are there, these potassium channels, we know they are closed here, closed here, and that is causing the further depolarization of the cell. So when the blood glucose levels are high, the potassium channels, they are closed. So the potassium ions, they are no longer moving outside of the cell, and that is going to cause the further depolarization, and that is inhibiting the glucagon secretion, isn't that? So this is the comparative table we have, and with the help of this table we can describe all sorts of the electrical activity, all sorts of the what we call as a, right from the action potential to the threshold potential to the resting membrane potential to the secretion of the insulin, inhibition of the glucagon, whole this thing, or even the secretion of the glucagon, inhibition of the insulin, all we can explain with this table. Now we will see some information regarding the insulin receptor. So this insulin receptor is a very important to understand the pathogenesis of the diabetes later on. So we will take some information about it. Insulin receptor gene is present over chromosome number 19, and this receptor is synthesized as a single chain polypeptide precursor or a proreceptor. It primarily matures in the endoplasmic reticulum, and the further maturation takes place in the Golgi bodies. Once it is formed, this insulin receptor, it is transported to the cell membrane through the transport vesicles. So this insulin receptor, once these insulin receptors they are formed, these receptors they are transported to the cell membrane through the vesicles there, and finally it gets incorporated in the cell membrane with alpha portion outside the cell membrane, and the beta portion becomes a transmembranous. We will see that. So this insulin receptor has got two parts, alpha subunit and the beta subunit. This alpha subunit we called as a extracellular part, and a beta subunit we called as a transmembranous. This extracellular part is there for the insulin. The insulin molecule is supposed to come and attach with the alpha subunit. The transmembranous portion, that is a beta subunit, we divides into three parts there. Which are these three parts? Small extracellular domain, single membranous segment, and the large intracellular domain. So this small extracellular domain, it lies outside, just outside the cell membrane. This single membrane segment, it is inside the cell membrane, whereas this large intracellular domain, it lies in the cytoplasm of the cell. So this is how we divide this beta subunit into the three parts. So if you can see this image here, in this image this is the cell here, and here we have this alpha subunit here, and this is the beta subunit here. This alpha subunit the red color, this is the alpha subunit here, and this alpha subunit is outside the cell membrane, and this is the beta subunit there. This beta subunit we can divide into three parts. The part of the beta subunit which is outside the cell membrane, the part of the beta subunit that is inside the cell membrane, and the part of the beta subunit that is outside the cell membrane. If we enlarge here, if you take this portion and just enlarge here, so this red color portion, this is the alpha subunit, this orange color portion, this is the beta subunit there, and this beta subunit we can divide into three parts. The part of the beta subunit that is lying outside the cell membrane, the part of the beta subunit that is inside the cell membrane, and part of the beta subunit that is like in the cytoplasm. The part which is outside is small, and part which is inside the cell membrane is a quite large one as compared to that. And these two parts, alpha subunit and beta subunit, they are attached to each other with disulfide bonds. Okay, and the insulin molecule, suppose this is the insulin molecule we have, then this molecule, let me draw with some other color. Okay, this is the insulin molecule, so it is supposed to come here and bind here with this alpha subunit, and this alpha subunit is going to stimulate the beta subunit, and the process will go on like that. So this is the information we should know. The important thing is this receptor, it has got two parts, alpha subunit and beta subunit, and this alpha subunit is attached with the beta subunit with the help of the disulfide bond, and this beta subunit, it has got three parts: extracellular in the extracellular part, the membranous part, that is the part which is lying actually in the membrane or piercing the membrane, and intracellular part which is in the cytoplasm. So that's all with the regarding the information of the insulin receptor. Now we will see the mechanism of GLUT4 transportation and the translocation. So this GLU stands for this glucose, and T stands for the transporter, that is glucose transporter means GLUT. And when we say glucose transporter, that means with the help of this transporter, glucose enters into the cell. So for the glucose molecule to enter into the cell, it requires GLUT there. Without glucose transporter, glucose molecule cannot enter into the cell. So various type of GLUT transporters, they are present in various cells there. So RBC, they have GLUT1 transporter. Then these pancreas, they have basically GLUT2 and GLUT1 transporter, and these neurons, they have GLUT3 transporter, and this GLUT4 transporter, they are in the muscles and in the adipocytes. Now very important thing, sorry, this GLUT1, GLUT2 and this GLUT3, these three types of GLUT transporters, GLUT1, GLUT2 and GLUT3, these three GLUT transporter, they are insulin independent. They do not depend upon the insulin. In fact, they are always present in the cell membrane. Means what? This GLUT1, it always present in the cell membrane of the RBC. This GLUT1, GLUT2, they are always present in the cells of the pancreas, where this GLUT3, they are always present in the cell membrane of these neurons. But this GLUT4, it is insulin dependent. Means this GLUT4, they are not always present in the cell membrane of the muscles and adipocyte. It requires insulin. For the translocation of these GLUT4 into the cell membrane, for the incorporation of this GLUT4 receptor in the cell membrane. It requires insulin, isn't that? So without insulin, this presence of the GLUT4 in these cell membrane is not possible. In fact, some few GLUT4, they are present in the cell membrane, but for what we call as a functional entry of this glucose molecule, it requires GLUT4 transporters to be present in the cell membrane, and once the insulin is there, it allows the entry of the glucose molecule into the cell through these GLUT4 transporter. Now we will try to see how this insulin cause the transportation and the translocation of the GLUT4. So I have drawn one cell here. This is one single cell here. Suppose this is the adipocyte, and we have a few minutes back we have seen the insulin receptor. So I have drawn one insulin receptor here, and this is for the insulin here. And probably this person has taken some food some few minutes back, and now the plasma blood glucose levels are raised. So all these G, this stand for the glucose, these glucose molecules, they are surrounding these cells, but they cannot directly enter into the cell because the GLUT4 transporters, they are not always present in the cell membrane of these muscle cells or the adipocytes. So, let us see what happens. So these GLUT4 molecules, these GLUT4 molecules, they are present inside these vesicles here, or these GLUT4 transporters, they are present inside the vesicles here, and these vesicles are there in the cytoplasm of these cells there. Okay, so I have drawn a few vesicles here in the cytoplasm, and these wire dots there, they are the GLUT4 transporters there, and these GLUT4 transporters are present inside these vesicles. Now, because the plasma blood glucose levels are raised, insulin is secreted. So these are the insulin molecules you can see here surrounding these cells, and this one of this insulin molecule will come and bind with this receptor here. We have just few minutes back we have seen there are two portions of the insulin receptor, alpha portion and the beta portion. This insulin molecule, it will bind with the alpha portion, isn't that? And once this insulin molecule binds with the alpha portion, it stimulates the beta portion of this insulin receptor. So let us come here. So insulin molecule binds with the alpha subunit, and once this insulin molecule binds with the alpha subunit, it stimulates beta subunit. Now in the beta subunit we have got one molecule there, what we call as a tyrosine kinase. Okay, so tyrosine kinase is present in the beta subunit, and this tyrosine kinase gets phosphorylated. So there is a phosphorylation of this tyrosine kinase which is present in the beta subunit, and the phosphorylation of the tyrosine kinase, it will cause phosphorylation of the insulin receptor substrate. This is the another protein molecule which is present in the cytoplasm. It gets phosphorylated because of the phosphorylation of the tyrosine kinase. So see the sequence. Insulin, so we have taken a food, plasma levels of the glucose are raised, insulin is secreted. We have seen whole the mechanism how insulin is secreted. This insulin molecule is there in the blood now, and this insulin molecule, it will come, and this is the adipocyte here, it will binds with the insulin receptor there, and it will bind specifically with the alpha subunit of the insulin receptor, and this alpha subunit then will stimulate the beta subunit, and in the beta subunit what we have a tyrosine kinase, and this tyrosine kinase will get phosphorylated. So tyrosine kinase phosphorylation, and once this tyrosine kinase gets phosphorylated, it will in turn cause the phosphorylation of the IRS. IRS means insulin receptor substrate. This is the molecule which is present in the cytoplasm. It will get phosphorylated, and the phosphorylation of this insulin receptor substrate will leads to various events or a cascade there. Various events will take place in the cell, and ultimately due to this event GLUT4 receptor transportation and translocation will take place. So these GLUT4 vesicles which are present here, these GLUT4, because of these various events, it will cause first transportation of these GLUT4 vesicles towards the cell membrane, and then the translocation or incorporation there. They will first fuse with, here you can see here, there will be first the fusion of these vesicles with the cell membrane, and the GLUT4 transporter will be released, and they gets translocated. You can say they get translocated here. So these various events or this cascade which started because of the binding of the insulin molecule with the alpha subunit ultimately cause these GLUT4 vesicles to move towards the cell membrane. They will fuse with the cell membrane. They will release these GLUT4 receptors or GLUT4 transporter there, and these transporter then they get incorporated in the cell membrane. So you can see these all these GLUT4 transporter, they are getting incorporated in the cell membrane, and through this GLUT4 transporter now these glucose molecules they can enter into the cell, isn't that? So for the entry of this glucose molecule into this cell, these GLUT4 are necessary, but these GLUT4 they are not always present in the cell membrane, as like this GLUT1, GLUT2, GLUT3, they are always present in the cell membrane, but this GLUT4 is not always present in the cell membrane. It is the insulin which requires for the incorporation of this GLUT4 transporter in the cell membrane, and whenever we take food, the insulin is secreted, it binds with this insulin receptor, it starts various events in the cells. These GLUT4 vesicles they are transported to the cell membrane, they fuse with the cell membrane, they release these GLUT4 vesicles, GLUT4 receptor, GLUT4 transporters, and then the glucose molecule can enter into the cell. So I hope that you got the point. Here if you see, I have just tried to show this event. So if you enlarge this portion of the cell here, so here we have a this insulin receptor here, this is the insulin molecule we have, and we know that insulin receptor it has got three parts, one part outside this beta, so the beta portion of the insulin receptor we can divide into two portions, one part which is outside the cell, this part there in the cytoplasm, and this part is there in the cell membrane, isn't that? And this is the alpha portion of this insulin receptor. So this insulin molecule and coming and bind with this insulin alpha portion of the insulin receptor, and this alpha portion of the insulin receptor then stimulating the beta portion, and the beta portion what we have a tyrosine kinase here. Okay, so this beta portion is there in the tyrosine kinase there in this the beta portion, and it will get phosphorylated once the beta unit is stimulated, and the phosphorylation of this tyrosine kinase will cause phosphorylation of the insulin receptor substrate. This is another molecule which is present in the cytoplasm, and this molecule, suppose these are the various molecules there, insulin receptor substrates, they will get phosphorylated because of this tyrosine kinase, and they will now initiate various events inside the cell, and ultimately these events cause GLUT4 transportation and the translocation, and ultimately this glucose molecule allowing the entry of the glucose molecule inside the cell. So this is how the whole thing happens inside the cell when when we take food as far as these muscles and adipocytes are concerned. Now we are going to see some terminologies. Those are very important to understand this diabetes. So let us go through these terminologies. So when the glucose is converted into glycogen, we call this as a glycogenesis, and it occurs where in the liver and the muscles. When the glucose is converted into triglycerides, that we call as a lipogenesis, and these triglycerides they are stored where in the adipocytes or fatty cells. Of course, this glucose is converted into fatty acid first of all, and these fatty acids then combine with the glycerol to form triglycerides. Then when the glycogen is converted into the glucose, this stored glycogen, when it is converted into the glucose, we call as a glycogenolysis. Very simple. Glycogenolysis is a process where the stored glycogen is converted into glucose. Now we will see this one more terminology, that is gluconeogenesis. In the process of gluconeogenesis, our body is deriving the energy from the non-carbohydrate sources, and non-carbohydrate sources means fat and proteins. Here these triglycerides, they are first broken down into fatty acids and glycerol, and we are getting energy molecule directly from these fatty acids, and we are getting glucose from this glycerol. These proteins, especially these glucogenic amino acids, after the process what we call as a deamination, where the amino group is removed from these glucogenic amino acids, and what remains is a carbon skeleton, and we get a pyruvate from that carbon skeleton, and this pyruvate that then enters into the cycle to give us a glucose. So in this process of glucogenesis, we are deriving the energy from the non-carbohydrate sources. Now see at the top here. Now okay, these two process, that is glycogenesis and this lipogenesis. Here we are storing the energy. Here we are storing the energy in these two processes. Whereas these two things, that is glycogenolysis and gluconeogenesis, in these processes we are using stored energy. We are using stored energy in this process. Now see at the top, when we take a food, what happens? Plasma blood glucose levels are raised. So in the plasma, glucose is available, and what happens first? The cells, they can directly use this glucose energy. They can directly use the glucose for the energy formation, and rest of the glucose that will be stored in the livers and muscles in the form of a glycogen. So first what will happen when the glucose levels are raised? This glucose may be directly used by the cell, and rest of the glucose or remaining glucose will be converted into glycogen, where in the liver and muscle, and that process we called as a glycogenesis, isn't that? If there is a excessive glucose, so first the cells, they have used remaining glucose is stored in the liver and muscles, and if there is a excessive glucose there, then that glucose will be converted into triglycerides, and that will be stored where? That will be stored in the fatty cells. So lipogenesis, in the process of lipogenesis, the excessive glucose is stored in the adipocytes, and when we are suppose we are having not taken the food for some time, we are in the fasting state, then plasma glucose levels are decreased, and when the plasma glucose levels are low, that will stimulate the process of glycogenolysis there. So here we have a glycogenolysis, and in this process, this glycogen which is stored in the liver and muscles, we have already stored this energy. So this stored energy is used by our body. In this process, what happens? Glycogen is converted into glucose, and that process we call as a glycogenolysis. Suppose we do not take a food for a prolonged time, prolonged fasting is there, then what will happen? This energy which is stored in the adipocytes and the proteins, they will start breaking down. So in a process of a in the state of a prolonged fasting, we derive the energy by the process of a gluconeogenesis. In the case of a prolonged fasting, we derive the energy from the gluconeogenesis. In this process, these triglycerides in the fatty tissues, they are converted into fatty acids, and the glycerol we get a glucose from the glycerol, and we get energy molecules from the fatty acids, and from the glucogenic amino acids we get a pyruvate, which then enters into the cycle to give us a glucose molecule there. So this is how the energy is managed inside our body. Now we will see some slides which are concerned with this topic. So let us see this slide here. So when we eat food, plasma glucose levels are raised, and this glucose is used by the cells in a following way. So which are the ways we are just talk used by the cells for the purpose of the immediate energy. Remaining glucose is stored as a glycogen in hepatocytes and the myocytes, means muscles, and excessive glucose is stored as a triglyceride in the adipocytes. That's what we have just seen. Storage of the glucose as a glycogen in the liver and a muscle is called glycogenesis. We have seen that. And storage of the glucose in the adipocyte is called as a lipogenesis. We know this. And during lipogenesis, glucose gets converted into the fatty acids, which combines with the glycerol to give us triglycerides. We also know this mechanism. Now during the need, glucose stored in the form of a glycogen in the liver is converted back to the glucose and released into circulation for the use. Okay, so when we need the energy, the first choice is a conversion of the glycogen into the glucose, and we have stored glycogen where? In the liver and in the muscles. But here we have to know that this glucose which is stored in the liver, when it is when we get a glucose from the stored glycogen in the liver, because this liver has got one important enzyme there, what we call as a glucose 6 phosphatase. This glucose 6 phosphatase, it converts this glucose 6 phosphate into a free glucose. But this the need, glucose stored in the form of a glycogen in the liver is converted back to the glucose and released into circulation for the use. So in this process, what happens? Glycogen is converted into glucose 6 phosphate, and this glucose 6 phosphate is converted into free glucose by the enzyme what we call glucose 6 phosphatase, isn't that? And glucose stored in the form of a glycogen in the muscles cannot be released into the circulation, as the muscles lack the enzyme glucose 6 phosphatase, which converts glucose 6 phosphate into free glucose. So we know this thing. Just try to put this here. Well, so in the liver, what will happen? This glycogen is converted into, this glycogen is converted into what? Glucose 6 phosphate, and this glucose 6 phosphate, it will be converted into free glucose by the enzyme glucose 6 phosphatase. Okay, so this enzyme is this enzyme, it is present in the hepatocytes, and that's why glucose 6 phosphate is converted into the free glucose, and this free glucose enters into the blood, okay, in the plasma. Now what happens with the muscles? Let us see here. In the muscles there, what will happen? Okay, let us. In the muscles, what happens? This glucose is converted, this glycogen now in the muscles, what happens? This glycogen is converted into glucose 6 phosphate. So in the muscles, this glycogen is converted into glucose 6 phosphate, but liver, so glucose 6 phosphatase, this enzyme is not present in the muscles, and therefore this glucose 6 phosphate cannot be converted into free glucose. So no free glucose means it cannot enter into the circulation, it cannot enter into the blood. So this glucose 6 phosphate can be used for the purpose of the energy by the muscle cells only. Our rest of the cells, they cannot use this glucose for the energy purpose, whereas in the liver we have a glucose 6 phosphate, we have a glucose 6 phosphatase which converts glucose 6 phosphate into a free glucose, and this free glucose enters into the blood, and our cells, they can use this glucose for the energy. So this is the difference there. So I think you got this point. And the hepatocytes as a glycogen in hepatocytes and the myocyte is referred to as a short term storage. So this glycogen which is stored in the hepatocytes and the myocytes, this energy which is stored in the hepatocytes and the myocytes in the form of a glycogen, this is referred to as a short term storage, means we can use this immediately when needed. Okay, so if we remain fasting for say some length of a time, we can use this glycogen as a source of immediate energy. Then the energy that is stored in the adipocyte is referred to as what it is referred to as a long term storage. Okay, so the triglycerides which are stored in the adipocytes, so this glucose, it is stored in or this energy which is stored in the adipocytes, this is been referred to as a long term storage, and this is used only during the prolonged fasting. Okay, so this stored energy in the fatty cells, this energy is used only when there is a prolonged fasting, and this has been referred to as a long term storage there. So during prolonged fasting, once glycogen stores are finished, see this process. During the prolonged fasting, once the glycogen stores are finished, or we can say the glycogen stores are already used and still we are not taken any food, then it is managed through gluconeogenesis. So rather than saying that they are finished, you can say when the glycogen stores are used, still the body is requiring the energy, then this energy we get by the process of a gluconeogenesis. And in this process already we have seen there is a lipolysis and there is a proteolysis there. In the lipolysis, it is a conversion of the triglycerides into fatty acids and the glycerol. These fatty acids they are converted into acetyl coenzyme A by the process of a beta oxidation, and this acetyl CoA then enters into the Krebs cycle to give us the energy there, and this glycerol it is converted into DHAP, which enters into glycolysis pathway to generate glucose. We know this process already. Then proteins are broken down into amino acids, and this glucogenic type of amino acids, we know alanine, it is glucogenic amino acids. So glucogenic amino acids enters into gluconeogenesis pathway to produce glucose. We know this glucose alanine cycle. So proteins, this basically this what we call as a glucogenic amino acids, we get a pyruvate from it, and pyruvate it enters into the cycle to give us a glucose molecule. So we get a glucose molecule from the glycerol and we get a glucose molecule from the glucogenic amino acids. Okay. Now we will see the pathogenesis of the diabetes, and we know that diabetes, it has got two types, type 1 DM and type 2 DM. In a type 1 DM, these autoantibodies and these autoreactive T cells, they destroys this pancreatic beta cells, and because of that there will be a deficiency of the insulin in the body, and that will result into the diabetes there in this patient type 1 DM, and it occurs in the children. That information we already have. This type 2 DM, these are the factors which are responsible for the type 2 DM, but we have already seen that type 2 DM insulin resistance is 1 and beta cell destruction is 2. These are the two factors which leads to the type 2 DM, insulin resistance, which is causing a beta cell destruction. So if you see grossly here in the type 1 DM, there is a beta cell destruction due to what? Due to autoreactive B cells and the autoantibodies, they are destroying beta cells there. And in the type 2 DM, this beta cell destruction is also been the responsible factor due to what? Insulin resistance. So it is the insulin resistance that occurs first, which has been a very prime importance thing, that insulin resistance, it is causing a beta cell destruction. In the end, it is causing lots of stress on the beta cell, that is leading to the apoptosis of the beta cell. So insulin resistance, beta cell destruction, ultimately we are getting type 2 DM. Okay. So here the causative factors are different here in both these conditions, and in a type 2 DM, this obesity, this sedentary lifestyle, these genetic factors and these hereditary factors, all these factors, they ultimately leads to what? Insulin resistance. We will see the details of this, how exactly they cause the insulin resistance. Of these factors, this obesity, sedentary lifestyle, we can consider as a single one, then the genetic factor and then the hereditary factors. Now this obesity is very important as far as the diabetes is concerned. The persons who are obese, they are more prone to develop diabetes, so as hypertension, so as IHD, so as stroke. So obesity is the prime factor as far as diabetes is concerned. It doesn't mean that those peoples who are not obese, they are having a less risk. It is not like that. Even a thin person can have a risk of a diabetes. So what is the reason that present in this patient which cause the diabetes? So when we talk of the obesity, we know that what we see is a body mass index, isn't that? Obesity, it is a generalized fat deposition there, and that we measures with a body mass index. But in those persons who are not obese, what is the reason they develop the diabetes? So in those patient, it is a visceral fat is a causative factor there. In those people's, visceral fat is the causative factor. The fat which is around the intestine, or the fat which is around the pancreas, the fat which is around the liver, this visceral fat is present in the excessive amount in these patients, even though they are not obese. Okay. So this visceral fat is a important factor in a patient where in a patient who are not obese. Now the person who is obese as well as lots of visceral fat, the chances of developing or a risk is very high. The person who is obese, again the risk is very high, and the person having a excessive visceral fat, then also the risk is very high. Now how we can measure this visceral fat? Maybe we go for the CT, or we can measure the waist there, and waist more than 40 centimeters in males is considered as a risky one, and in a females it is 35 centimeters. Okay. So waist more than 40 centimeters in male and more than 35 centimeters in a female is considered as a risk factor. So obesity, excessive visceral fat, sedentary lifestyle, genetic factors, hereditary factors, all they can lead to the insulin resistance. Now now what about this genetic factor? We already knows that over the chromosome number 19, a gene for insulin receptor is present. A gene for the insulin receptor is present over this chromosome, and any mutation in this gene, okay, any mutation in this gene, that can leads to what? A defective, that can leads to a defective insulin receptor. A insulin receptor which is a defective one can be formed, and when this insulin receptor is embedded in the cell membrane, because it is defective, can insulin combine with this receptor which is defective one? No, insulin cannot combine with a defective receptor, and these patients, they will develop a insulin resistance. So this is how this genetic factor works as far as the insulin resistance is concerned. And these hereditary factors are concerned, usually there is a history, parental history there about the diabetes. The mother or the father or both of them may be suffering from the diabetes, or even grandfather, grandmother, they may be suffering from the diabetes. And this history we get with the hereditary factors. So this is how this these causative factors works with the insulin resistance. Now we'll see in detail how this obesity cause insulin resistance. So we'll first understand the pathogenesis of the obesity in short, and also we will see how this obesity cause insulin resistance. So now we'll see the pathogenesis of the obesity in short. So look at the top here. Chronic overnutrition and excessive caloric intake. So it should be chronic overnutrition and excessive caloric intake, and this will result in what? It will result in a more and more fat generation, and this fat will get deposited where? In the adipocytes. So this fat will be deposited in the adipocytes, and this because of more and more fat deposition in the adipocytes, that will result in the increase in the size of the adipocytes. So increase in the size of the adipocytes means hypertrophy of the adipocytes, and this increase in the size of the adipocytes will result in hypoxia of the adipocytes. Why? Basically because even if the size is increased, the blood supply will remain the same. There will not be change in the blood supply, but now size is more, and that will result in hypoxic state in these adipocytes. On the other hand, here, because of increased fat deposition, it will result in increased ER stress, endoplasmic stress. ER means endoplasmic reticular stress. This increase in the endoplasmic reticular stress, what is the reason? The reason is now, so as to store this fat, these adipocytes, they requires more proteins to form a membranes there. So as to form the membranes, these adipocytes, they needs more protein, and these more proteins they are getting generated in this endoplasmic reticulum, and because of that, this endoplasmic reticulum, they are working very hard, isn't it? And this we called as a increased ER stress, and this increased ER stress, of course, it will result with what? Increased oxidative stress is there, and this more oxidative stress is resulting in the free radicals. So more oxidative stress will cause more generation of the free radicals. So see what is the scenario now. These adipocytes, they are hypertrophied because of the increased fat deposition. They are hypoxic, and because of the more ER stress, it is resulting more free radicals there. Now we will see more details in the next slide, but before we could proceed, just again look at the top. This chronic overnutrition and the excessive caloric intake that will result in increased fat deposition in the adipocytes. So, and it is causing hypertrophy of the adipocytes, causing decreased capacity to store the fat. So, once these adipocytes, they are hypertrophied, once their size is increased, now beyond this, there will not be any further increase in the size, means now their capacity to store the fat is over. Once a certain size is reached, once the certain hypertrophy is reached, more than that they cannot increase in the size. That means now they cannot store more fat than they can store with this hypertrophy. So eventually what we can say that in the end a certain point is reached, so that now they cannot store more fat. So now their capacity to store the fat is decreased, or you can say the capacity to store the fat is over, and that is going to result in the release of these free fatty acids in the blood. Okay, so once that storage capacity is over, now it will release these free fatty acids into the blood, and these it will start releasing free fatty acids in the blood, and that is going to cause ectopic fat deposition in the hepatocytes and myocytes. And these free fatty acids which are released in the blood, they will start getting deposited in other organs inside the body, like hepatocytes, like myocytes, like blood vessels, like abdomen. So these fat will start getting deposited outside these adipocytes, and that we called as a ectopic fat deposition in the that we call as the ectopic fat deposition. And these ectopic fat, which are the sites of ectopic fat deposition, hepatocyte, myocytes, is blood vessels, that is abdomen, etc. So this is the scenario we have. Now we'll see the next slide. Now look here, in this slide, this excessive fat accumulation in the adipocyte, we have already seen in the previous slides that there will be excessive fat generated if anybody is eating more and more food, or anybody is eating more and more caloric diet, then that is going to result in a excessive fat generation, and this fat is going to be deposited in the adipocytes. And this fat which is deposited in the adipocyte, what will happen once more and more fat deposited in the adipocyte, that will result in a ectopic fat deposition. So that these adipocytes they will release these fatty acids in the blood, and these these fatty acids that will start getting deposited where? In the hepatocytes, in the myocytes, in the abdomen, in the vessels, blood vessels, isn't that? And this fat deposition is there on one hand, and on the other hand we have already seen this also, that there will be hypertrophy of the adipocytes. This accumulation of this fat will result in the hypertrophy of the adipocytes, and there will be hypoxia of these adipocytes. Because of this hypertrophy, there will be hypoxia of the adipocyte, and also there will be increase in the endoplasmic stress, and that is resulting in oxidative stress, and of course the free radicals, we know that. So more ER stress, more oxidative stress, more hypoxia, hypertrophy, this is the scenario we have. Now because of this hypertrophy, because of this hypoxia, because of this increased ER stress, oxidative stress, these adipocytes, they very important there. So whole these events of this hypoxia, increased oxidative stress, ER stress, that is going to cause secretion of the these chemokines from these adipocytes. So adipocytes, these chemokines are getting secreted in these adipocytes, and these chemokines which are secreted from these adipocytes, that will cause these macrophages to reach at these adipocytes. Okay, so there will be a movement of the adipocytes towards there will be a movement of the macrophages towards these adipocytes because of the chemokines. So these chemokines, as we have learned, they attracts these macrophages. The macrophages gradually start gathering at these adipocytes, and these macrophages and these adipocytes, they now secretes what's these cytokines, what we call as a interleukin 6 and TNF alpha. Okay, so these two cytokines, interleukin 6 and TNF alpha, they will be secreted by these macrophages and adipocytes. They will do what? So these cytokines, they will induce chronic inflammation of the fat deposited tissues, isn't that? So these interleukin 6 and TNF alpha, they will be released in the blood. These cytokines, they will spread throughout, and what it will do? It will cause a chronic inflammation of the cells where the fat is deposited. So we have already seen that this excessive fat is getting deposited where it is deposited. Already it is there in the adipocyte, and this fat, ectopic fat, is getting deposited in the liver, then in the blood vessels there, then in these myocytes here, muscle cells here, and so myocytes here means skeletal muscles and in the abdomen. So whole this fat is getting deposited over these multiple things here, and whole these cells right from these myocytes, right from these hepatocytes, these blood vessel cells, then abdomen, everything, everywhere we have getting a chronic inflammation. So whole these cells where the fat is deposited, they will be chronically inflamed. So this chronic inflammation, this word is very important. This chronic inflammation, this word is very important. So there will be a chronic inflammation of the fat deposited tissue. Why this chronic inflammation is there? Because of this interleukin 6 and TNF-alpha. This is the most important pathogenesis now. This chronic inflammation of these adipocytes, the chronic inflammations of the ectopic sites where the fat is deposited is very important factor in the diabetes. Why? That we will see later. But here this word, that chronic inflammation of the cells where the fat is deposited is very important. Okay. And when I say chronic inflammation, means the chronic inflammation of the adipocytes, chronic inflammation of the hepatocyte, chronic inflammation of the skeletal muscle cells, chronic inflammation where every cells is going under the chronically inflamed because of this ectopic fat deposition inclusive of the adipose tissue. Okay, so adipose tissue and whole these ectopic fat deposited sites cells, they are getting inflamed, is okay, and this inflammation is a chronic one. Okay, so till now again just we'll see in short. So this accumulation of the fat in the adipocyte is going to cause ectopic fat deposition in the hepatocytes, in the skeletal muscle cells, in the abdomen and in the vessels. And here this fat deposition is causing hypertrophy of these adipocytes, hypoxia of the adipocytes, increased ER stress and oxidative stress of the adipocytes, and that is going to result secretion of the chemokines, and these chemokines are released, and these chemokines are causing the macrophages to reach at these adipocytes, and these macrophages and these adipocytes, they are now secreting this interleukin 6 and the TNF alpha. These are the cytokines, and these cytokines, they are released into the blood, and now these cytokines, they are going to reach at the sites where the ectopic fat deposition and this adipocyte themselves and this ectopic fat deposition site cells, they are getting inflamed with this interleukin 6 and TNF alpha. So induces the chronic inflammation of the fat deposited tissue, and that causing increased ER stress of the fat deposited tissue. So this chronic inflammation of the fat deposited tissue is there, and plus there will be increase in the ER stress of the fat deposited tissue. Now why ER stress is increased? Because this ectopic fat which is deposited in these other cells like hepatocytes or these skeletal muscle cells, there also because this fat is getting deposited, there also the endoplasmic reticular stress will be increased. So as to accommodate this fat, they have to form this membranes there, and there needs more proteins there, and for this more proteins they have to work hard their endoplasmic reticulum machinery, and that is going to results into what? More stress, more free radicals. Okay, so there in these cells also there will be generation of the more free radicals. We will see that process separately, but here this ER stress of the fat deposited tissue also. So in addition to increased ER stress of the adipose cells, there will be increase in the ER stress of the other fat deposited sites also, isn't that? So until now I think you got this point there. Now next just we'll read, but we'll try to understand in a different slide. See here what I have mentioned. Chronic inflammation leads to activation of the pathways like JNK and JAK-STAT, which causes a phosphorylation of the IRS insulin receptor substrate and decreases the production of the insulin receptor substrate. So this has been a IRS, it is a protein molecule present in the cytoplasm there, and this IRS molecule is getting phosphorylated here. So this chronic inflammation of these hepatocytes, chronic inflammations of these muscle cells is going to cause the activation. This chronic inflammation is going to activate JNK and a JAK-STAT pathway. So these two pathways are there, and these two pathways they are getting activated, and these activated path this JNK and JAK-STAT pathways, they are releasing certain cytokines there, and these cytokines they are going to cause the phosphorylation of the insulin receptor substrate and decreases production of the insulin receptor substrate. So they are causing phosphorylation of the IRS, as well as they are decreasing the production of the IRS. Now what is the meaning of the phosphorylation of the IRS? What exactly is IRS, and how there will be decrease in the IRS? Whole this process we'll try to understand in the separate slide. But the important thing is this chronic inflammation of these adipocytes and these hepatocyte as well as that of the adipocyte, whole they are chronically inflamed. Adipocytes, these hepatocytes, these skeletal muscle cells, they are chronically inflamed, and this chronic inflammation is going to activate the pathways what we call JNK and JAK-STAT pathway. So we will see what this JNK and JAK-STAT pathway, what effect they are causing, how they are causing the phosphorylation. All these things we will try to see in the separate slide just in a few minutes. But before we could proceed, see here, this increased ER stress in the adipose tissues, in the these skeletal muscle tissues and these hepatocytes, liver cells, that is going to result into this increased free radicals we already know. Okay, so there will be increase in the free radicals, and why? Because of the increased oxidative stress. So this increased ER stress is ultimately causing increase in the free radicals, we already know. And again this increased ER stress is going to result in the increased misfolded proteins. So why the misfolded proteins are increased? Because this ER machinery is working very hard so as to provide the protein for the membrane formation, so as to store the fat. Because this ER machinery is working very hard, over the period it start producing misfolded proteins, and these misfolded proteins, more and more misfolded proteins are formed in this ER machinery. So these misfolded proteins will ultimately results in a decreased insulin receptor, because for the insulin receptor we needs proteins, and now we have a more number of misfolded proteins, and that misfolded proteins will cause a decrease in the insulin receptor, because for insulin we also require some proteins, and misfolded proteins are of no use, isn't that? Misfolded proteins they are not going to help us to form this insulin receptor or so many other required proteins there. So these misfolded protein formation ultimately results in a decreased insulin receptors, and this decreased insulin receptor means insulin resistance, in other words, isn't that? These decreased insulin receptors, if the number of insulin receptors are decreased, that will result in what? If number of insulin receptors are decreased, it is a sort of a insulin resistance. So why? Because these receptors are there where insulin is supposed to bind. These insulin receptors are there so as to provide binding sites to the insulin, and now these binding sites are decreased. So in one way it is a sort of a insulin resistance there, this is one thing. Second thing, see here, these free radicals which are formed in this whole process, what is happening with them? These free radicals, they in turn are inducing what? They are in turn causing chronic inflammation of the fat deposited tissues. Okay, so these free radicals which are formed in this process, they are again responsible for the chronic inflammation of this fat deposited tissue, right from these adipocytes, then these skeletal muscle cells, or these hepatocytes, all these cells which are already inflamed, again it is adding to the inflammation. So if you see, these processes are going to be repeatedly or in multiple ways they are causing the inflammation, or they are helping the process of inflammation in these cells. So these free radicals, they are again adding to this chronic inflammation there. Already this oxidative stress, this increased ER stress, oxidative stress, hypoxia, hypertrophy, it has secreted these chemokines. The macrophages are reaching to the sites, and then these macrophages and these adipocytes, they are generating this interleukin 6 TNF alpha. It is causing chronic inflammation of the fat deposited tissue. Again these free radicals, they are again adding to this chronic inflammation, and this chronic inflammation, as I have told you, it is leading to activation of the pathways like JNK and JAK-STAT pathways, and this JNK and JAK-STAT pathway is going to cause phosphorylation of IRS and decreased production of the IRS, that we will see later. But what happens is, whole this process of this phosphorylation of the IRS and decreased production of the IRS, it is resulting into disturbed insulin signaling pathway. So insulin signaling is disturbed, and that is going to result in the insulin resistance there. So this insulin resistance we are getting from with the whole this pathogenesis. This insulin is resistance we are getting with this mechanism also, and this insulin resistance we are getting with this mechanism also. Okay, so ultimately we are getting an insulin resistance, but it is not the sole mechanism which is causing insulin resistance. Multiple mechanisms are there, but the unique thing is a fat deposition, excessive fat deposition. So it is a excessive fat deposition, or it is a obesity, or it is a visceral fat. Whole this fat deposition is ultimately resulting in insulin resistance by various or by multiple mechanism. We will see some details of this mechanism in the next slide. See this slide here. Pro-inflammatory cytokines which are released by the macrophages, we have seen interleukin 6 and TNF alpha, they are secreted by the macrophages and of course by the adipose tissues also. Why? Because these adipocytes, they are flooded with the fat, and various sequence of events we have seen: hypoxia, increased ER stress, increased free radicals, whole these things are stimulating these chemokines, and the chemokines are formed inside these adipocytes, and these chemokines, they are attracting the macrophages to move towards them, and now these macrophages and adipocytes, They are secreting what? Interleukin 6 and the TNF alpha, isn't that? Now, these cytokines are responsible for chronic inflammation. So, these cytokines, they are causing chronic inflammation in the hepatocytes, in the skeletal muscle cells, in the adipocytes, and that is going to cause the insulin resistance. Okay. So, this is part number 1. Then see what is next. Also the inflammatory cytokines produced by, so inflammatory not cytokine, inflammatory kinases I will say. So inflammatory kinases produced by the hepatocytes, myocytes, adipocytes, they are responsible for insulin resistance. These inflammatory kinases, why they are produced, we have just seen. JNK stat and the JAK stat pathway inside the cells is getting activated, and this activated JNK and the JAK stat pathway, it is releasing these inflammatory kinases. Now, what is the difference between these cytokines and these kinases? Cytokines, they are released in the blood, isn't that? The cytokines, they are released in the blood, whereas these kinases, they are released inside the cells. These kinases, they are released inside the cell. These cytokines, they are causing inflammation from the outside, because they are released in the blood, they are outside these cells, and they are causing the inflammation from the outside, whereas these kinases, they are acting from the inside. So these cytokines, they are acting from the outside, whereas these kinases are acting from the inside, we can say, and they are producing the inflammation of this cell. Ultimate result is the same. What? They are causing the inflammation there, isn't that? They are adding to this inflammation there, and they are ultimately resulting in the insulin resistance. So these cytokines, they are causing a chronic inflammation resulting in the insulin resistance. These inflammatory kinases produced by these cells, they are also causing a resistance there. We will see the exact process how these kinases which are produced by JAK-STAT and JNK-STAT pathway, by this JNK and JAK-STAT pathway, how they how they ultimately causes the insulin resistance, that we will see in a short while. But the important process is what? There is a inflammation of these cells, fat deposited cells, and this inflammation of the fat deposited cells is ultimately resulting in the insulin resistance. That's the important lesson in the pathogenesis of the diabetes. See this flow chart here. Already we know we have learned the mechanism of this GLUT4 transportation and the translocation. But for the sake of convenience, I will just repeat again, and then we will go for the pathological event there. So this insulin molecule, it combines with the insulin receptor, more specifically alpha portion of the insulin receptor, and once this alpha portion is stimulated, that stimulates the beta subunit there, and once this beta unit is stimulated, it causes phosphorylation of the tyrosine kinase. This tyrosine kinase, which is present over the beta subunit there, and once this insulin, it combines with the alpha portion, it stimulates the beta portion of this insulin receptor, and over this beta portion we have a tyrosine kinase, it gets phosphorylated. Once this tyrosine kinase is phosphorylated, it in turn causes the phosphorylation of the insulin receptor substrate. We know that this insulin receptor substrate, it is a protein molecule which is present in the cytoplasm, and this phosphorylation of the tyrosine kinase, it causes the phosphorylation of this insulin receptor substrate. Once this insulin receptor substrate is phosphorylated,
it leads to various events inside the cell. This cascade is there, and finally we gets increased GLUT4 transportation and translocation. So this phosphorylation of this IRS, it results into GLUT4 transportation and a translocation, and finally what happens, there is a increased glucose uptake. Once these GLUT4 transporters they are translocated in the cell membrane, they starts this shifting of this glucose from outside of the cell to the inside of the cell. So increased glucose uptake is there. So this is what the normal mechanism or normal sequence of the events occurring in the cell. Now we have a scenario that here we have a pathological event, that there is a obesity there. We have seen that how in this obesity there is a ectopic fat deposition. We have already seen there is a chronic inflammation is there. Then there is a increased ER stress. Also there is a increased oxidative stress resulting into increased free radicals there. So these increased free radicals, this increased ER stress, this inflammation, chronic inflammation, this ectopic fat deposition, all these events they are causing what? Activation of JNK and JAK-STAT pathways. All these events, those we have already gone through, they are resulting into JNK and JAK-STAT pathway activation. And once there is a JNK and a JAK-STAT pathways activation, that results into formation of the protein kinases. We are getting various type of protein kinases, and these protein kinases they start doing the phosphorylation of the insulin receptor substrate. Okay. So these events which we have already gone through, this chronic inflammation, this increased free radicals, all these events they cause the activation of the JNK and JAK-STAT pathway. We get a protein kinases through this JNK and JAK-STAT pathway, and these protein kinases they start doing phosphorylation of the insulin receptor substrate. Normally this insulin receptor substrate, this IRS, is phosphorylated by what? Tyrosine kinase. And now this insulin receptor substrate is getting phosphorylated by what? Protein kinases. This phosphorylation we called as a serine phosphorylation of the IRS. Okay. This abnormal mechanism of phosphorylation we called as a serine phosphorylation of the IRS. And once this IRS undergoes this serine phosphorylation, it starts decreasing the GLUT4 transformation and translocation, because it is following the abnormal way. It decreases GLUT4 transportation and the translocation. Once there is a decreased GLUT4 transportation and translocation, that results into what? Decreased glucose uptake, and that in other words means insulin resistance. So we are getting insulin resistance by this way here. So what is the difference, basic difference between these two things is what? Normally this phosphorylation of this IRS is caused by tyrosine kinase, and in abnormal way this phosphorylation is caused by protein kinase, isn't that? And that we call as what? Serine phosphorylation of the IRS. And when there is a serine phosphorylation of the IRS, that decreases GLUT4 transportation and translocation and decreased glucose uptake. So that's what I have mentioned right here. Serine phosphorylation of the IRS, it results into decreased GLUT4 transportation and the translocation, thereby decreased glucose uptake. So very easy to understand. If you follow these flow charts very well, then you will not forget this whole mechanism there. Serine phosphorylation of the IRS is not the only factor which is responsible for the reduction in the glucose uptake. There is one more factor which is contributing to this mechanism. So, let us see that factor here. This protein kinases which are doing this serine phosphorylation of the IRS, these protein kinases, they reduce the production of the insulin receptor substrate. These protein kinases which have been produced because of this JNK and JAK-STAT pathway activation there, they are also reducing the production of the insulin receptor substrate. So, both these mechanisms, serine phosphorylation of the IRS and decreased production of the IRS, they togetherly they are causing decrease in the glucose uptake. So, this because there is a reduction in the production of the insulin receptor substrate, there will be less GLUT4 transportation and translocation there, and also finally it will result in reduced glucose uptake. So, both these factors, serine phosphorylation of the IRS and decreased production of the IRS because of these protein kinases, they are finally resulting into decreased GLUT4 transportation and translocation and the decreased glucose uptake. So, if you follow this flow chart, then there should not be any difficulty in understanding it. So, now we will see how the insulin resistance ultimately leads to the destruction of the pancreatic beta cells by the process of apoptosis. So, in the beginning only we have said that as far as type 2 DM is concerned, it is a insulin resistance and it is a pancreatic beta cell destruction causing deficient insulin production. These are the two factors which ultimately leads to type 2 DM. Already we have gone through all the mechanism of the insulin resistance. So, see here what we have mentioned. Lipotoxicity, it causes chronic inflammation and increase in the ER stress or endoplasmic reticulum stress. Now, what is lipotoxicity? We have just seen. So, lipotoxicity is the mechanism where the excessive fat is getting deposited in the adipose tissue, and once these adipose tissues they are overflooded, this fat is released into the blood, fatty acids they are released into the blood, and there will be ectopic fat deposition, and these adipose tissues because of over fat accumulation, they are starting the process, they are releasing chemokines, and these chemokines they are attracting these macrophages. Inflammation is started, TNF alpha, then interleukin 6 they are released into the blood and they are leading to the chronic inflammation. So, we have gone through all this process. So, lipotoxicity, it is accumulation of a fat or over saturation of the fat in the adipocytes, and there is a ectopic fat deposition, and especially the accumulation in these adipocytes, it is leading to the formation of interleukin 6 and this interleukin 6 and TNF alpha, and it is leading to the chronic inflammation. We have seen this process and we have given stress on this word, chronic inflammation. So, this chronic inflammation and increased ER stress. Now, why ER stress is increased? We already know, because now the cells require more proteins to store this fat to form the membrane, isn't that?
and that's why there will be increased ER stress. So this chronic inflammation, increased ER stress is there. Now this increased ER stress, what it does, it increases the misfolded proteins there, and this increases the free radicals there. So increase in the ER stress causes increased misfolded proteins, and increased ER stress ultimately it is going to free, more and more free radicals. So more free radicals, more misfolded proteins are there, isn't that? So that ultimately this increased misfolded proteins and this increased free radicals, whole this thing we includes under this lipotoxicity. So lipotoxicity is causing, see how many things. The lipotoxicity is causing chronic inflammation. This lipotoxicity is causing this misfolded proteins. This lipotoxicity is causing increased free radicals there. This is one side. Now what about this glucotoxicity? See this glucotoxicity. Insulin resistance is there. Now we have got a insulin resistance, and this is because of the insulin resistance, what will happen? That will cause decreased glucose uptake. So this insulin resistance, it will cause decreased glucose uptake, and because of the decreased glucose uptake, there will be increased blood glucose. So plasma levels of the glucose will be high, and these raised plasma levels will cause persistent stimulation of the beta cell to produce insulin. We have seen how this glucose enters into the beta cells. When glucose levels are high, more and more glucose molecule enters into the beta cells. They cause more ATP production, shutdown of the potassium channel, which ultimately leads to the more production of the insulin. Here, because the glucose levels are persistently high, that is going to cause persistent stimulation of the beta cells to produce the insulin, and this insulin requires what? It requires more proteins. Insulin, it is a protein molecule. So this endoplasmic reticulum of this beta cell is also again under the stress because of this persistent stimulation to produce the insulin. So that we refer to as this has been a glucotoxicity. So because of the glucotoxicity, the ER stress is high, and also because of the lipotoxicity, again the ER stress is high in this hepatocytes and this muscle cells, and also this lipotoxicity is affecting the pancreatic beta cells also. But not only that, the pancreatic beta cells, they have got additionally stress there of the glucotoxicity. They have additional stress of the glucotoxicity, because as we know, these beta cells, they are independent of insulin, isn't that? Glucose can enter into these beta cells through GLUT1 and GLUT2 receptors there, and because of this glucose is entering through this GLUT1 and GLUT2, there will be a persistent stimulation to form more and more amount of insulin, and that is leading to that we called as a glucotoxicity. So cells are getting exhausted, not only because of the deposition of the fat, but also because of the higher glucose levels, and they are producing more insulin and they are getting exhausted. So the point is, this chronic lipotoxicity and this glucotoxicity, they are ultimately leading to the apoptosis. So these beta cells, they are exhausted. They are exhausted because of the lipotoxicity stress, because of the glucotoxicity stress. They are getting exhausted, and ultimately a death signal is carried out, what we call apoptosis of the beta cell. The beta cell is undergoing the process of apoptosis, and because the beta cell is undergoing the process of the beta apoptosis, there will be decrease in the number of the beta cell, and this decrease in the number of the beta cells means less insulin production, and less insulin production means what? We are getting a diabetes there. Okay. So insulin resistance and decreased insulin production, ultimately we have landing up with a disease called as a diabetes.
I again repeat, it is a insulin resistance which is through various mechanism is causing the apoptosis of the beta cell, thereby decreasing the insulin production. Ultimately, we are getting this disease diabetes here. Now we will go through the clinical features of the diabetes, and first we will see three important clinical features, that is polyuria, polydipsia, and last polyphagia. Okay. So let us first see the mechanism of polyuria, how it occurs there. So we normally know that when the blood glucose levels are normal, some amount of a glucose gets filtered at the filtration barrier, but almost all these glucose is getting reabsorbed at the proximal convoluted tubules, PCT. So in the urine we do not have, or almost we do not have, any glucose molecules. Now this mechanism is there with a normal blood glucose level. When the blood glucose levels are more, as in the diabetes, when we have a hyperglycemic state, more amount of glucose is getting filtered at the filtration barrier, and this glucose cannot get completely absorbed at the proximal convoluted tubules. Why? Because the proximal convoluted tubules, they have the limited capacity to reabsorb the glucose molecule. So when the blood glucose levels are normal, and when only a limited amount of glucose is getting filtered at the filtration barrier, these proximal convoluted tubule, they are able to reabsorb almost all the glucose molecule present present there. But when we have a hyperglycemic state, when the blood glucose levels are high, more and more glucose is getting filtered, more and more glucose molecules are getting filtered, and these PCT, they do not have the capacity to absorb these glucose molecules, and the glucose will start getting losing in the urine, or it will start getting passing further in the loop of Henle distal convoluted tubules, and this result in the creation of the osmotic gradient. So we start getting a glycosuria, passing of a glucose, and because of what? Because of the limited capacity of the PCT to reabsorb the glucose, and that will result in a osmotic gradient across the renal tubules. Because the glucose is passing in the renal tubules, it will create the osmotic gradient there, and this osmotic gradient will drag in water and sodium. So this osmotic gradient which is created, it will drag in water and the sodium from the outside into the tubules, and that will result in the polyuria. So more water is lost, and that will cause a polyuria, increased frequency of the urine. This more loss of water will cause a hypovolemic shock, decreased blood pressure. Now this is how the mechanism of polyuria occurs. Now this polyuria will result in polydipsia. The mechanism I have mentioned in short here, but we will try to see the separate mechanism in the separate slide there. But here this polyuria occurs because this glycosuria, loss of a glucose in the urine, is causing creation of the osmotic gradient, and this osmotic gradient is dragging in the water along with the sodium into the tubules, and that is resulting into the condition what we called as a polyuria. Now we will see the mechanism of polydipsia. See, we have already seen the mechanism of the polyuria, and in this mechanism what we have learned is we are losing water and the sodium, isn't that? We are losing more water and the sodium through the urine, isn't that? So when we are losing more water and sodium, what happens is we lose more water as compared to the sodium. Okay, as compared to the sodium, the loss of water is more. Now if we are losing more water as compared to the sodium, that will cause a osmotic gradient across the cell membrane. Suppose this is the cell, this could be any cell in the body, and now we have a situation that the person he is having a polyuria, he is losing more water and sodium in the urine. Now what I have said is he is losing more water as compared to the sodium. This more loss of water as compared to the sodium, it results in a more sodium in the extracellular compartment, means the concentration of the sodium in the water is more. If the concentration of the sodium in the water is more, that means hypertonicity is increased, isn't that? If the concentration of the sodium is more in the water, then it means that we are creating a more hypertonicity. So there will be increased hypertonicity in the extracellular fluid due to more loss of water as compared to solutes, especially sodium, isn't that? So this sodium is sodium concentration is more in the extracellular compartment there, isn't it? So if the sodium concentration is more in the extracellular compartment, it creates an osmotic gradient. Okay, so just like we have seen one osmotic gradient in the renal tubules, and there we have a polyuria. Now here another osmotic gradient is created where in the cell membrane, all the body cells they have this osmotic gradient there. And what will happen if the osmotic gradient is created across the cell membrane because of the hypertonicity in this extracellular compartment? So the compartment which is outside the cell, extracellular compartment, it will start dragging in water from the intracellular space to the extracellular space. So this sodium in the extracellular compartment or hypertonicity in this extracellular space, it will start dragging in water from intracellular compartment to the extracellular compartment, and this dragging in of water from intracellular to the extracellular space, that will cause shrinkage of this cell, because the water loss inside the cell, it will cause the cell to shrink in. Okay, so this dragging water from the intracellular to the extracellular space and results in a shrinking of the cell. Now there are some specialized cells in the hypothalamus, and why these cells in the hypothalamus are specialized? Because they have got the very specific type of feature there, they have got the stretch receptors. So this shrinking of the cells, including the specialized cells in the hypothalamus. So all the cells they are getting shrinked, but these specialized cells in the hypothalamus, which are also getting shrinked because of this mechanism, these cells in the hypothalamus, they have got the stretch receptor in the cell membrane. So these specialized cell in the hypothalamus, they have got this stretch receptor there, and these stress receptors in these cells, they are getting activated, and they sense. So when the cell is getting shrinked, this cells receptor, these specialized receptors in these cells, they are getting activated, and they are sending a neuronal signal to the thirst center in the cerebral cortex. So we have a thirst center in the cerebral cortex, and these cells, they are sending a message to this center in the cerebral cortex, and that is responsible for the polydipsia. So we are getting the feeling of drinking more water. So this is how the polydipsia is caused. So see, if you see whole this sequence of the event, so these stress receptors are getting activated where in the hypothalamus. Now these stress receptors are only present in the cell membrane of the hypothalamus, even though all the body cells are getting some getting some shrinkage there. Only the specialized cells in the hypothalamus, they have the stress receptor there and they are getting activated there. Now why these stress receptors are getting activated? Because of a shrinking of the cells. So why the cells are shrinking? The cells are shrinking because of a loss of a water from intracellular to the extracellular compartment. Why there is a loss of water from intracellular to extracellular compartment? Because of the osmotic gradient. Why the osmotic gradient is created? Because of a more loss of water as compared to the sodium. Now why this water and sodium loss is occurring? Because of the osmotic gradient in the renal tubules. Now why the osmotic gradient in the renal tubule is created? Because of the glycosuria. And why the glycosuria is there? Because this PCT have a low capacity or limited capacity to reabsorb the glucose, and in the hyperglycemic state more glucose is lost or more glucose is filtered at the filtration barrier, and this PCT cannot reabsorb them. This is how whole the mechanism we can talk in a reverse way also. So I hope that you got this both mechanisms of that is the sequence of event which are responsible for polyuria, and those are responsible for the polydipsia. Now we will see the mechanism of this polyphagia, but before we could proceed, we will see certain normal things and then we will go for that. Ghrelin is the hunger hormone, what we know. So ghrelin is secreted by the ghrelin cells which are present in the lining of the stomach. Of course, these ghrelin cells are present in the duodenum also, in the jejunum also, in the pancreas also. But bulk of the ghrelin cells they are present in the lining of the stomach, and these ghrelin cells they are responsible for the feeling of a hunger, that we know. Now we also know that when the levels of the insulin are high, the levels of the ghrelin are low, and when the levels of the insulin are low, levels of the ghrelin are more, isn't that? So the levels of the insulin are high means suppose anybody has taken a food, glucose levels are raised, that will result in increased insulin level, and that will suppress the secretion of the ghrelin. And on the other hand, if anybody is on a fasting for some period, then that will reduce the blood glucose level, that will result in a decrease in the insulin secretion, and that will stimulate the secretion of the ghrelin. Okay. So whole this process of low insulin and high insulin, low ghrelin, and low insulin and high ghrelin, both these things they are opposite to each other. Okay. So why we should remember this? Basically we will try to understand, when we try to understand what happens with type 1 and type 2, we will comes to know that. But there is one more thing. There are one specific neuron what we call as the AGRP neurons. These AGRP neurons they are present in the arcuate nucleus of the hypothalamus, and these AGRP neurons which are present in the arcuate nucleus of the hypothalamus, they have the receptors. They have the receptors for these ghrelin. Okay. So when ghrelin is secreted, it is going to bind with these receptors, and it is responsible for the feeling of the hunger. So these AGRP neurons which are present in the arcuate nucleus of the hypothalamus, they have the receptors for this ghrelin, and ghrelin is going to bind with this receptor and we are going to get the sensation of the hunger. Now once we have knowledge of these things, then let us come to the condition what we call type 1 DM and a type 2 DM. In a type 1 DM, what is the scenario? We know that in a type 1 DM, these pancreatic beta cells, they are destroyed because of the autoimmune process. We know that. So we have a insulin deficiency, isn't it? So insulin deficiency is there, low levels of the insulin, that will result in a high levels of the ghrelin. And what is more important, in a type 1 DM, the insulin levels, they will be always low. The insulin levels, they will be always low, and that will result in a more ghrelin, and more ghrelin always they will persistently stimulate these AGRP neurons, and person will persistently eat. That is why he will get a polyphagia. So because the ghrelin levels will be persistently high because of the persistently low level of insulin, this high ghrelin level will persistently stimulate this hunger center in the hypothalamus, and the person will persistently eat, polyphagia. Now see what is the scenario with a type 2 DM. In a type 2 DM, we have seen that initially there is a insulin resistance, and later on this insulin resistance, it causes beta cell destruction. So we have two conditions, or we can say two stages there. One is a resistance stage, and second stage, this resistance stage is resulting into the beta cell destruction. In the initial stage where there is only the resistance stage, at that stage what is the scenario? In the resistance stage, the insulin levels are high. Why? Because whenever there is a insulin to the resistance to the insulin, these beta cells, they are persistently stimulated to secrete more insulin, okay? Because resistance to insulin is resulting in a high blood glucose level, and these high blood glucose levels, they are causing more and more stimulation of the insulin, isn't it? So this more and more insulin is stimulated, therefore in the resistance stage of this type 2DM, the levels of the insulin are high, and if the levels of the insulin are high, that will result in a low levels of the ghrelin. So ghrelin level will be low. So high insulin means low ghrelin. Now even though the ghrelin levels are low, still the patient has got a polyphagia. Even though the ghrelin levels are low in this resistance stage, still the patient is having a polyphagia. Why? So try to understand this mechanism. Even though the ghrelin levels are low, these AGRP neurons which are there in the arcuate nucleus, they becomes more sensitive, they becomes more expressed. So there will be more expression of the AGRP neuron, there will be more there will be increase in the sensitivity of the AGRP neurons, and even though low ghrelin levels are there, because the neurons are more expressed, they are more sensitive, they are secreting, they are causing more hunger sensation, even though the ghrelin levels are low. So once again see this, here in the resistance stage, insulin levels are high because beta cells are still preserved. In the resistance stage, the beta cells are still preserved, and because of the resistance stage, what will happen, these glucose levels are very high, and these high glucose levels, they will cause pancreatic beta cells to secrete more insulin. So insulin levels are high in this stage, and because the insulin levels are high, the ghrelin levels are low, okay? But still these low ghrelin levels, they are able to give the hunger sensation. The question is why? It is basically because this AGRP neuron which I have just seen, which have got receptors for this ghrelin, these AGRP neurons, they are more expressed, they becomes more sensitive to the ghrelin, and even though the ghrelin levels are low, these AGRP neurons, because they are more sensitive, they are causing the hunger sensation. And now in the latter stage, when the beta cell destruction also start, these levels of the insulin comes down, the low levels of the insulin, and that will cause increase in the ghrelin levels, and now they will stimulate these AGRP neurons by the same mechanism, and now these increased ghrelin levels, they will still cause the hunger. Okay, so in both these stages we are having a hunger. Only thing is here the sensitivity here, even though the low levels of ghrelin are there, because these AGRP neurons are more sensitive, they are more expressed, we are getting a sensation of the hunger, and here it is a high ghrelin levels which is causing the hunger sensation there. Now we will see some more. Now once we understood this mechanism, this is not the only way this low ghrelin can cause this hunger sensation. This is not the only way this low ghrelin levels we can get a hunger sensation. There is another thing there which can increase the hunger sensation. So we will try to see that in the next slide. So just now we have seen that these even though in the initial stage of the DM these ghrelin levels are low, even after that because of increased sensitivity of the AGRP neurons, we are getting the hunger sensation. Now this is not the only way we get a hunger sensation in this situation. There is another way we get a hunger sensation in this situation. Let us try to see that. So see at the top, even though plenty of glucose present in the plasma, because of insulin resistance, glucose cannot enter into the cell. So we have a situation of a type 2 DM. We have a high insulin level because beta cells are not destroyed, but there is a resistance of the insulin, and therefore glucose are not able to enter into the cell sufficiently, and these cells are remaining deprived of the energy inside of the hyperglycemia, and this cellular energy deficit is sensed by hunger center in the brain. So these AGRP neurons, they are able to sense this energy deficit, and this AGRP neuron, because they are sensing this energy deficit, it is going to cause a persistent feeling of a hunger, that is a polyphagia. So these AGRP neurons, they can also directly sense this energy deprivation, and that also resulting into the hunger sensation. So see this last sentence here. Initially in type 2 DM, ghrelin levels are low, but more expression of the AGRP neuron is contributing to polyphagia. So we have already seen that, but energy deprivation is sensed by the AGRP neuron in the arcuate nucleus, is acting as a main cause of the polyphagia. So the contribution of as far as hunger is concerned, the more contribution is done by this energy deprivation sensation by these neurons, and also of course the increase in the sensitivity of these neurons is also contributing to the hunger mechanism there. So this is bit complex, but we can understand if you just try to consider the whole this mechanism in a sequence. There should not be any difficulty. I hope that you got this. Now we will see the mechanism of the weight loss in a patient of the diabetes. We know that in a type 1 DM, these beta cells, pancreatic beta cells, they are destroyed by the autoimmune mechanism, and therefore the insulin levels are very low, or even the insulin may be absent. And in a type 2 DM, this insulin resistance, which finally results into apoptosis of the pancreatic beta cells, and there will be reduction in the number of the pancreatic beta cell, that results into decreased insulin production. So these low insulin levels, they results into high glucagon level, and this high glucagon, it stimulates the process what we call as a gluconeogenesis. This gluconeogenesis is the process where we derive energy from the non-glucose sources, that is a protein and the fats. So there is a breakdown of the protein, what we call proteolysis, and there is a breakdown of the fat, what we call lipolysis in this process, and that finally results into weight loss. So in this process of the gluconeogenesis, finally we get a weight loss because of the breakdown of the protein and because of the breakdown of the fat. Now here one more thing we should know, that if this process of lipolysis is accelerated, if the process of the lipolysis is accelerated, then it may result into ketoacidosis along with weight loss, because the acetyl coenzyme A we get with this process of lipolysis, we know that it undergoes beta oxidation to give us the energy, but this what we call as a oxidative stress is there. Then rather than going into or rather than following this beta oxidation process, this acetyl coenzyme A, it may enters into ketogenic pathway, and that leads to diabetic ketoacidosis. So if the lipolysis is accelerated, we may land up with a ketoacidosis. So this is regarding the weight loss process. See here, the process or mechanism of a proteolysis. We have already learned that these raised glucagon levels and low insulin levels, they are stimulants for this process of a gluconeogenesis. And in addition to this cortisol, this catecholamines, and this growth hormones, they are also been stimulatory factors for the process of the gluconeogenesis. And in this process of a proteolysis, the proteins are broken down into the amino acids, and these amino acids, they undergo the process of deamination. In the deamination, amino group is removed from these amino acids, amino group is taken off from these amino acids, and this amino group, as we know, it is converted into urea, which is then excreted in the urine. This remaining part, after the deamination of the amino acid, remaining part, which is a carbon skeleton, which is then converted into intermediates of the TCA cycle. Okay, this carbon skeleton, which is then converted into the intermediates of the TCA cycle or directly into the pyruvate. Okay, so we may get intermediate of the TCA cycle, any of the intermediate of the TCA cycle, or it may directly converted into pyruvate, and in the end we get a glucose molecule from these intermediates, or we may get a glucose molecule from the pyruvate. We also know that this glucose we get from the glucogenic type of the amino acids. Okay, so we cannot get a glucose molecule from non-glucogenic amino acids. Glucogenic amino acids like alanine, we get a glucose molecule. So this is how this process of the proteolysis occur, and because of this protein breakdown we get a weight loss. So we get a weight loss because of the protein breakdown. Now next we will see the mechanism of lipolysis. Now see here, in this flow chart we will see how the lipolysis occurs, and we know that this lipolysis mechanism is responsible for the weight loss. But in the same slide we will see also one another feature of a diabetes, that is a ketoacidosis also simultaneously. Okay. So this process of lipolysis is responsible for the weight loss, and when this lipolysis is accelerated, it can cause ketoacidosis. Okay, we will see this mechanism here. So these triglycerides, they are broken down into fatty acids and glycerol. In the process of lipolysis, these triglycerides, they are broken down into fatty acids and the glycerol, isn't that? These fatty acids, they combines with the serum albumin. These fatty acids, they are combines with the serum albumin, and it is then transported to the livers, to the muscle, to the kidneys, and in the mitochondria of these cells, these fatty acid, it combines with coenzyme A, CoA, and once this fatty acid it combines with this CoA, it is getting activated, and this combination then breaks down into three parts here: NADH, FADH2 and acetyl CoA. So this fatty acid and this CoA, it combines. This combination, what we call as the acyl CoA, the fatty acid and CoA combination we call as a acyl CoA, and this acyl CoA then breaks down into three parts: NADH, FADH2 and acetyl CoA. This NADH and FADH, by the mechanism of phosphorylation, they generates ATP molecules. But this acetyl CoA, it undergoes beta oxidation, and then it is converted into NADH and FADH2, and then we get ATP molecules. See very carefully here, this acetyl CoA, it is undergoing what? Beta oxidation to form NADH and FADH2. When when the beta oxidation process is accelerated up to certain extent, it can convert this acetyl CoA into NADH and FADH2. But when there is a more stress, when there is a more oxidative stress there, this acetyl CoA, which is in the excess quantity, it enters into the ketogenic pathway. So that means that when these fatty acids, they are broken in a abundant amount, whatever the acetyl CoA what we are getting, it is all this acetyl CoA cannot undergo beta oxidation process. In fact, this acetyl CoA enters into the process what we call ketogenic pathway, and when it happens, this acetyl CoA enters in the ketogenic pathway when there is a oxidative stress. When more amount of oxidative stress is there, this acetyl CoA, it enters into the ketogenic pathway. So rather than going into the beta oxidation pathway, now this acetyl CoA is shifting to the ketogenic pathway, And this acetyl-CoA in this ketogenic pathway, see what it is doing here. This acetyl-CoA here in the ketogenic pathway, it is going to be converted into three molecules: beta hydroxybutyrate, acetoacetate and the acetone. Of these three, this acetone is exhaled through the expiratory air during the respiration, and in the patient of a diabetic ketoacidosis, what we says is there is a sweet odor. This sweet odor we are getting is because of the acetone there. Remaining these two molecules, beta hydroxybutyrate and the acetoacetate, they are highly acidic and they give rise to metabolic acidosis. Okay, and this acidosis is a high anionic gap type of metabolic acidosis, and this metabolic acidosis that causes Kussmaul's respiration. And what is Kussmaul's respiration? It is a deep and the rapid breathing pattern is there in the Kussmaul's respiration, and this this mechanism ultimately is a part of this diabetic ketoacidosis, isn't that? So, this acetyl-CoA which is entering into the ketogenic pathway, again I repeat, it is getting converted into these three parts. Of these, acetone is responsible for the sweet odor that we are getting in the patient of a ketoacidosis, whereas these two molecules, beta hydroxybutyrate and acetoacetate, they are highly acidic and they are causing metabolic acidosis, and this acidosis is a high anionic gap type of a metabolic acidosis, and in this process we get a Kussmaul's respiration. What is the characteristic of the Kussmaul's respiration? The respiration pattern is a deep and a rapid type of a respiration, and ultimately this diabetic ketoacidosis, this patient they needs very prompt management. So this is how this fat catabolism ultimately leads to ketoacidosis as well as to the weight loss. So as far as this weight loss is concerned, it is because of the proteolysis and the lipolysis, and this ketoacidosis, when there is a excessive fat breakdown, it leads to ketoacidosis also. Okay, so the ketoacidosis, very important thing is there is a excessive fat breakdown, and because of this excessive fat breakdown, there will be what we call as a more amount of oxidative stress, and this acetyl-CoA which is formed in this process, rather than undergoing the beta oxidation, it starts shifting to the ketogenic pathway, and once it enters into this ketogenic pathway, it gives rise to diabetic ketoacidosis. So we have already gone through these clinical features. Polyuria we have already seen, polydipsia we have already seen, polyphagia, then the mechanism of weight loss, then the dehydration also we have seen. We have also gone through diabetic ketoacidosis where we are getting Kussmaul's respiration presented as a dyspnea, and only remaining clinical feature is a diabetic coma. Okay, so how this diabetes complication we get a diabetic coma that also we will see. So of these 7 important things, we already have gone through 6. This last one we will see now. Now we will see one more complication of a diabetes, that is a hyperosmolar coma or a hyperosmolar hyperglycemic state, what we call as a HHS. Already we have we know certain facts. This hyperglycemia, it results in a glycosuria, loss of the glucose in the urine. This loss of the glucose in the urine, it results in a increased osmotic gradient, and because of that it results in a polyuria. In this polyuria there is a loss of water along with the sodium, and it results in what? Dehydration, and also increased with and also increase the osmolarity. We have learned that increase in the osmolarity because the loss of the water is more as compared to the sodium, and that results in a more concentration of the sodium in the extravascular in the extracellular space there, and this more concentration of the sodium in the extracellular space, it results in a dragging of the water from the intracellular space to the extracellular space. So, shift of the fluid from the intracellular to the extracellular space because of this increased osmolarity. And why this osmolarity is increased? Because loss of water is more as compared to the sodium, and this concentration of the sodium is more outside the cell, and this results in dragging of water from intracellular to the extracellular space, and this results in a dehydration of the cell. Okay, it results in a dehydration of the cell with a shrinkage. Dehydration and shrinkage of the cell, inclusive that of the cerebral cells or these neurons or these brain cells, they are also getting shrinked due to this loss of water, and that result in altered sensorium, altered consciousness, and that we refer to as a hyperosmolar hyperglycemic state or a hyperosmolar coma. Now, in this condition, usually the blood sugar levels, if you do with a glucometer, they are almost high, and one more thing is there that usually in this condition some degree of insulin is there, and therefore it is preventing this ketoacidotic state. Okay. So, so usually also we call this condition as hyperosmolar hyperglycemic non-ketoacidotic state, okay, or coma. So, this is how whole the thing we can explain as far as this HSS condition is concerned. Now, here we will try to see one more concept that is a glycosylated hemoglobin. So, this what exactly is this glycosylated hemoglobin? We will try to see here. This glucose, it combines spontaneously and irreversibly with the hemoglobin. So, this glucose in the blood, this has a tendency to combine with the hemoglobin there, and this once it combines with this hemoglobin, it easily combines with the hemoglobin. That's the thing number one. And second thing is this combination is irreversible. Okay, two things are there. Glucose combines spontaneously, this is point number one, and it is irreversible process. Once glucose it combines with the hemoglobin, it does not give it off, and therefore it is an irreversible process. And this combination of the glucose and the hemoglobin we call as a glycosylated hemoglobin. Okay. We know that the lifespan of this RBC where this hemoglobin is present, how much is the lifespan? 90 to 120 days. So, we can roughly say 3 to 4 months, isn't that? And this amount of the glucose which is combining with this hemoglobin, it depends upon the concentration of the glucose in the blood. So, more the concentration of the glucose in the blood, more the glucose level in the plasma, more it combines with the hemoglobin. Okay. So, more glycosylated hemoglobin if the sugar levels are high, and the process is irreversible. Two things we have seen, the process is irreversible, and more the amount of glucose, more is the glycosylated hemoglobin. And also I have said that this lifespan, as we know, it is 90 to 120 days. So just testing this amount of a glycosylated hemoglobin in the blood, it gives rough idea regarding how much could be the glucose levels in the last 3 to 4 months. So it gives some rough idea regarding that. It gives some average value of the blood sugar in last 3 to 4 months. So rather than depending upon the blood sugar value of a particular day or a particular time, here we can estimate the blood sugar level, average blood sugar levels in the last 3 to 4 months. That is the advantage with this glycosylated hemoglobin. So there are certain points here. One more thing is there. We'll just go through this. This glycosylated hemoglobin HbA1c, it test measures the glycated hemoglobin, which hemoglobin that has irreducibly bonded with the glucose molecules in the bloodstream. The percentage of the hemoglobin that becomes glycated is directly proportional to the average glucose concentration in the red blood cells. And the lifespan of these RBCs 90 to 120 days. The HbA1c test is a key tool for diagnosing the diabetes and monitoring long-term blood sugar controls. Okay, so so as to adjust the dosages, it helps a lot and also gives the idea of average blood sugar levels in last 3 to 4 months. And here we have got one more table here, and in this table we can just go through this. If glycosylated hemoglobin is 4, the average blood sugar is 65, it is 4.2, it is 72. Likewise, we can calculate the blood sugar, average blood glucose levels. So here up to 15 we have mentioned, and we expect in a diabetic patient to keep HbA1c below 7. So in that sense, if you see, this is the figure here, 168, 161 or 154. So these are the approximate figures that we are aiming at in a patient of diabetes. If it is less than that, it is well and good, but at least this much levels we should keep in our mind. Now, whatever we have just discussed, just try to put it on the board in this whatever we have just discussed, let us try to put it on the board here. See, glucose plus hemoglobin, we are getting glycated hemoglobin, isn't that? And this is been a one-way process. Once the hemoglobin is glycated, once it is combined with glucose, this process cannot be reverted back. So here this reversal is not possible. Okay. So this glycated hemoglobin, it is a permanent reaction there. Now see here, these are some glucose molecule I have drawn, and this is the RBC, and in the blood we have a glucose molecule as well as the RBC. Okay, so what will happen? These glucose molecules, see here, these are dotted glucose molecules are there, and we have a, so yeah. Now whatever we have just discussed, try to put here on the board. This glucose plus hemoglobin, we get a glycated hemoglobin, and this glycated hemoglobin, it cannot be reverted back to glucose plus hemoglobin. So it is a one-way reaction there. Glucose plus hemoglobin, we get a glycated hemoglobin, and this glycated hemoglobin, it is a permanent molecule there. It cannot be reverted. That's what I have shown here. Now in the blood we have a glucose molecule as well as RBCs there, and in the RBCs, as I have shown here, these are the hemoglobin which is present inside these RBC. Now this glucose, it combines with this hemoglobin molecule, and we get here glycated hemoglobin. So these dots here, they are representing glycated hemoglobin, and also we have a non-glycated hemoglobin here. Okay, so once this hemoglobin is glycated, we know it is irreversible. So we know that the lifespan of the RBC is 90 days to 120 days, and this glycated hemoglobin will remain as it is until these RBCs are there. So in this RBC we have some glycated hemoglobin also, and a non-glycated hemoglobin also, isn't it? So this glycated hemoglobin, it gives us idea regarding the blood sugar levels in last 3 months on an average. This glycated hemoglobin, because it cannot be reverted, it will remain until the lifespan of that RBC. And also what we know is this amount of glucose, amount of the glucose present in the blood and the amount of the glycated hemoglobin present in the blood, they are proportional to each other, meaning what, this amount of glycated hemoglobin, it is proportional to amount of the glucose. So it means that more the glucose, more is the glycated hemoglobin. Now we will see chronic complications of the diabetes. There are 3 important things we are going to see. One is a diabetic neuropathy, then diabetic retinopathy, and also diabetic nephropathy. So first we will see diabetic neuropathy. We know that in a diabetic neuropathy, these nerves, they are getting damaged, and simply we know anatomically these nerve fibers, they are covered with a myelin sheath, and the myelin sheath is supported by the Schwann cells. So nerve fibers at the center, it is covered by the myelin sheath. Of course there will be gap in between, gap in the sheath there, what we call nodes of Ranvier, and this myelin sheath, it is supported by the Schwann cells. When we say that this there is a damage to this nerve fibers, or there is a diabetic neuropathy, all these things, right from Schwann cells, myelin sheath, and also these nerve fibers, all of them are getting damaged. This nerve fiber damage we call as a axonopathy, and this myelin sheath damage, the term is a demyelination, and Schwann cell damage is also there. Then what are the causative factors for this diabetic neuropathy? So these are the things I have mentioned here. So glucotoxicity and the lipotoxicity. So both these terms, glucotoxicity, lipotoxicity, we have learned already, and they are also applied here. So glucose toxicity, this high blood glucose level, it is going to increase the metabolic stress, as well as it is going to increase the osmotic stress also, and there will be a lipotoxicity also, and this lipotoxicity is also going to increase this metabolic stress here. So all in all, this increased metabolic stress
and the osmotic stress, it is causing the damage of these nerve fibers. Then there will be microvascular changes. So the blood vessels which are supplying these nerve fibers, these capillaries, there will be damage to this microvascular capillaries there, and the damage in the sense the endothelial layer is getting damaged, and ultimately damage to these capillaries is leading to reduction in the oxygen supply. So this reduction in the oxygen supply and the nutrients that will leads to the damage to the nerve fibers. So microvascular changes occurring in these patients that is leading to reduction in the oxygen supply to the nerve fibers, reduction in the nutrients to the nerve fibers, and they are getting damaged. And lastly, very importantly, inflammation of the nerve fibers. So we have seen this chronic inflammation, this word chronic inflammation, we have already learned what is the meaning of the word chronic inflammation as far as diabetes is concerned. And this chronic inflammation is causing this TNF alpha and then interleukin 6 as a part of a generalized mechanism. These nerve fibers are also inflamed there because of this interleukin 6 and this TNF alpha, and this is also damaging the nerve fibers. So glucotoxicity, high blood glucose level leading to the metabolic stress, increase in metabolic stress as well as the osmotic stress, then lipotoxicity, increasing this metabolic stress here, microvascular changes in the blood vessels supplying the nerve fibers causing reduction in the oxygen supply, and the inflammation of the nerve fiber as a part of a chronic inflammation occurring in the diabetes. All these things are damaging these nerve fibers, this myelin sheath and these Schwann cells there. Then let us try to see certain symptoms we are getting with this damage. So here peripheral neuropathy is occurring, and what will happen? Sensory nerve, when there is a damage to the sensory nerve, what will happen there? It will cause a tingling, numbness, burning sensation and a sharp pains. Okay, so if you see this patient, diabetic patient, usually what they complains of, they complains of a numbness there, they complains of a sharp pains there, and also they complains of a burning sensation. Then this damage to this motor nerves is concerned with, or motor neuropathies, they are concerned with muscle weakness and a loss of reflexes. These are the two things we usually come across, muscle weakness and the loss of reflexes. And damage to the autonomous nerves, what it results in? Gastroparesis. Gastroparesis, as far is concerned, we get both either constipation or diarrhea, or both constipation followed by diarrhea, diarrhea followed by the constipation. Both patterns we can see in this patient. So gastroparesis is very common. Then postural hypotension. So because suppose if the patient is in a supine, lying in the supine posture, if he sits up, then there will be a decrease in the blood pressure and patient will feel a giddiness, and this we call as a postural hypotension. Then erectile dysfunction is another feature we get in a patient of a diabetes, and urinary incontinence. So these are the commonest features: gastroparesis, postural hypotension, erectile dysfunction and urinary continence. These are the commonest feature we come across in a patient of a diabetic neuropathy there. Then in the management, pain management is very important. Okay, in a diabetic patient, the management of the pain is very important, and usually we use gabapentin or also this serotonin norepinephrine reuptake inhibitor is also available. The drug is duloxetine. Also we have a drug what we call as a nortriptyline, which is available with this gabapentin. So depending upon the condition we can use these drugs.
Then foot care. This food care is a very important aspect in these patients due to loss of pain and the temperature sensation due to the neuropathy. Proper hygiene and wearing the footwear is very much essential. Okay, so because of a loss of a sensation of a pain and the temperature, so as to avoid any damage to the foot, they needs to wear footwear, and that can avoid whatever the loss because of this loss of a sensation. So care of a foot is a very important aspect in patients of a diabetes, along with his pain management there. And this gastroparesis, urinary incontinence, erectile dysfunction, all these complaints which are concerned with the damage to the autonomous nervous system, specific treatments are available to all these dysfunction that can be done. And lastly, the physiotherapy in a patient where there is a motor weakness or there is ataxia there, we can make use of a physiotherapy. So that's all with diabetic neuropathy. So now we will see another complication of a chronic diabetes, that is diabetic retinopathy. So this diabetic retinopathy, in short, by definition, it is a microvascular disorder, and here in this diabetic retinopathy, that means that there is a damage to the blood vessels in the retina. Very simply to say, that damage to the blood vessels in the retina. And the causative factors again are the glucotoxicity and the lipotoxicity. Now we already knows what is the meaning of this glucotoxicity and lipotoxicity. They are causing increase in the stress, and this increase in the oxidative stress, and also we know that this chronic inflammation, okay, both these processes, they are leading to damage to the endothelial cells. So in a diabetic retinopathy, which is a microvascular disorder, because of the glucotoxicity and the lipotoxicity which are causing this increase in the oxidative stress plus chronic inflammation, it is leading to the endothelial cell damage. Now damage to the endothelial cells, we can divide it into two parts here. Now when we are dividing this into two parts, this part here, they are the early changes which are occurring in the patient of the diabetic retinopathy, and on this side these changes are occurring late, or in the, we can say, as a part of a advanced retinopathy, we can say. So when we are dividing this endothelial cell damage, in the early stage, what happens is there will be increase in the vascular permeability, and because the vascular permeability is increased, there will be a oozing of the fluid outside, and that is going to cause, this fluid leakage is going to cause a retinal edema, and that we call as a macular edema more specifically. So macular edema is there because of the increase in the vascular permeability, and this is the early change we are getting in the patient of a diabetic retinopathy. Now this macular edema we call this as a non-proliferative. Okay, this retinopathy we called as a non-proliferative type of a retinopathy. Now see here. After that, gradually as the disease progresses, these capillaries which are supplying this retina, the capillaries which are supplying to this retina, they are getting occluded. Okay, they are gradually start occlusion of the capillaries, those are supplying retina, and once occlusion is started, it leads to the retinal ischemia here. So occlusion is followed by retinal ischemia. Once there is a retinal ischemia, there will be a release of a vascular endothelial growth factor. Vascular endothelial growth factor, that is what we call as a VEGF. What this vascular endothelial growth factor does? this vascular endothelial growth factor, it causes angiogenesis. Some new vessels are formed there. It is causing angiogenesis. New vessels are generated, or that we also called as a neovascularization. And this retinopathy which we are getting here in the form of angiogenesis or a neovascularization, that is referred to as a proliferative type of a retinopathy. Okay, here we have seen non-proliferative, here this we called as a proliferative type of a retinopathy. So very easy to understand. Early changes is a vascular permeability leading to what? Macular edema, and this macular edema it is referred to as a non-proliferative type of a retinopathy. Late changes or advanced changes, capillary occlusion is taking place. It is causing retinal ischemia, that is causing release of a vascular endothelial growth factor, and this ultimately leading to the angiogenesis. New vessels are formed, and this has been called as a proliferative type of a retinopathy. So once we know this, now we will go on this side here. So here we have tried to compare in between these two types of retinopathy, or two phases of the disease we can say. Here this is the early phase of the retinopathy, and it is the advanced phase of the retinopathy. So in a non-proliferative, this has been an early phase here, and this proliferative, it is the advanced phase here. Second point, leakage of the capillaries leading to the macular edema. Already seen, there is an increased vascular permeability, it is causing leakage of the capillary fluid is getting oozing out, and that is leading to the macular edema. Here, whatever the angiogenesis we are getting because of the vascular endothelial growth factor, see angiogenesis, new abnormal and fragile blood vessels in the retina are formed in the retina and the vitreous. We know the vitreous. So in the vitreous and the retina, new blood vessels are formed, but these blood vessels, they are abnormal one and they are fragile one. Okay, so both features are there. Abnormal blood vessels and the fragile blood vessels are formed, and where in the retina and vitreous by the process of angiogenesis we have just seen. And these blood vessels which are abnormal and fragile one, they are leading to blood vision to the blood vision to severe vision loss or a floating or even a blindness. See these things. These angiogenesis or these newly formed blood vessels which are abnormal one and a fragile one, they are leading to what? Blood vision is there, or it could be a severe vision loss, or there could be a floaters, we can say floaters moving, and also even a complete blindness it can lead to. Okay. Then see here, no symptoms in a early stage as far as this non-proliferative type is concerned. No symptoms in the early phase, or there could be some amount of a blood vision due to the macular edema. Okay. So some degree of blood vision we may get, or a patient may be asymptomatic in a non-proliferative type here. So this is how we can compare. Now the last one here, complications like vitreous hemorrhage and retinal detachment can occur. So these are the most serious complications, that is this vitreous hemorrhage or the retinal detachment. So this is how we can compare these two phases of a diabetic retinopathy, and that's all with this complication of the diabetes. Now we'll see one of the complication of the chronic diabetes, diabetic nephropathy. So we know that in the kidneys we have a filtration barrier, and in the filtration barrier we have 3 layers there, endothelial cells, basement membrane, and the podocytes. So all these 3 membranes they get damaged with the diabetic nephropathy here. And what is the cause of the damage of these 3 layers? as we have already seen these two words, glucotoxicity and this lipotoxicity, they are responsible for the increased oxidative stress, and also we know that there is a chronic inflammation. We have seen the meaning of the word chronic inflammation with the diabetes. So it is a chronic inflammation, and this glucotoxicity and lipotoxicity, they are responsible for the damage to the filtration barrier. Then in addition to this, there is also damage to the renal tubules also, and this renal tubular damage is in the form of inflammation followed by the fibrosis. So first it starts with the inflammation of the renal tubules, and as the disease advances, it turns into the fibrosis there. Okay. So in a diabetic nephropathy, we have a damage to the filtration barrier, as well as there is damage to the renal tubules also, and that results into these features, that is proteinuria, then hypertension because of the activation of the RAS system, renal angiotensin aldosterone system. It is getting activated, and that is causing hypertension and renal failure, of course chronic renal failure. So chronic renal failure, this hypertension and the proteinuria, these are the three features we get with diabetic nephropathy. Then very important findings in a patient of the diabetic nephropathy, that is Kimmel-Wilson nodules. These Kimmel-Wilson nodules, as I have mentioned, they are round to oval nodules. They are acellular or hypocellular, and they are eosinophilic. Okay, so they are eosinophilic, they are acellular or the hypocellular, and they are round to oval in shape, and they develop where in the mesangial matrix. They develop in the mesangial matrix, and they are composed of type 4 and type 6 collagen, also this laminin and the fibronectin. Okay. So these nodules are a diagnostic of a diabetic nephropathy, and therefore this Kimmel-Wilson, these Kimmel-Wilson nodules are very important as far as this diabetic nephropathy is concerned. And then we'll go for the management of the diabetic nephropathy. So see the basic things, we should have a strict glycemic control, HbA1c below 7 we should try to keep, and strict control of the blood pressure there with ACE inhibitors and ARBs. Then the third thing is SGLT2 inhibitors we can use along with these two things. We can use SGLT2 inhibitor, and they are renoprotective and also cardioprotective one, and also we can use this mineralocorticoid antagonist. The drug is finerenone, and it is also been a renal and a cardioprotective mechanism, and it prevents the inflammation process and the fibrosis also. Now how these drugs act, this finerenone, it blocks the aldosterone receptor present at the distal convoluted tubule. So we know that at the distal convoluted tubule, aldosterone receptors are present, and physiologically these aldosterone they reabsorbs sodium, and they excretes in exchange what has been excreted, potassium. So sodium is reabsorbed and potassium is excreted. Now because these receptors, aldosterone receptors, are getting blocked with this finerenone, this reabsorption of the sodium and excretion of the potassium is prevented, okay, with this drug. Now while using the drug we should be very cautious, because it can cause hyponatremia. Why? Because just now I told you that it prevents the reabsorption of the sodium. So it can cause hyponatremia as a side effect, and hyperkalemia because it prevents the excretion of the potassium, so that can lead to the hyperkalemia. So this caution you should take, you should watch for hyponatremia and hyperkalemia while giving this drug. So that's all with a diabetic nephropathy. As we know, this diabetes is of two types, type 1 and the type 2. As far as type 1 DM is concerned, we know that insulin is not produced in the body, and therefore we need to give insulin externally. So insulin is a must doing part as far as type 1 DM is concerned. So we have to give insulin in these patients. Along with that, we may use this drug metformin depending upon the situation, but insulin is a must one. Okay, we have to give insulin in this patient when we are treating type 1 DM. Okay. Then as far as this type 2 DM is concerned, we have two options. One is a OHD, or a second one is a insulin. Usually in the initial stage we start with a OHD, and as the years progresses, usually the patient may be shifted to the insulin, or we may give the combination of a OHD plus insulin, or even may use a insulin alone depending upon the condition. So the point is, in the treatment of the diabetes in a type 1, insulin is a must. Along with that, we may use metformin as an additional drug, whereas in a type 2 DM we have two options, OHD and insulin, and depending upon the condition we may choose one of them or both of them. Now we will see some detailed information regarding the insulin, various insulin available in the market. We will see what are their types, their durations of action, their peak levels, as well as some combinations they are available, and also we will see the information regarding the oral hypoglycemic drug also. Now see in this table here, in this table I have divided the insulin depending upon their duration of the action into three categories: short or rapidly acting insulin, intermediate acting insulin, and the long acting insulin. This in this category of short and rapid acting insulin, we have three insulin: human insulin, human aspart, and the human lispro. In the intermediate category, we have four insulin: NPH, which we also called as a isophene insulin. Second one is a lente insulin. Third one is a protaminated aspart, and fourth one is a protaminated lispro. Protaminated aspart and a protaminated lispro. And in the long acting category, we have two insulin, glargine and the ultra lente. So all these category we have made on the basis of a duration of their action. Now see here, this human insulin, so we are talking of this category first. This human insulin, it is a short acting insulin. Human insulin, what we call as a injection actrapid, okay, actrapid. So this human insulin, it is a short acting insulin, but it is a more duration of action than aspart and the lispro. So if you compare between this human aspart and human lispro, which are included in this category, so we are comparing human insulin with a human aspart and human lispro. Okay, this human aspart and human lispro, if you see, they are rapidly acting insulin. We will see the meaning of all these things. They are rapidly acting insulin. These insulin are rapidly acting insulin, but as far as duration is concerned, this human insulin, its duration of action is more as compared to human aspart and human lispro. And as far as the onset of the action is concerned, human aspart and human lispro, they acts more quickly than the human insulin, or more fast than the human insulin. I again repeat the things. We are looking after this first category. In the first category, we have three insulin: human aspart, and human lispro. Of these, human insulin is a short acting insulin, whereas human aspart and human lispro, they are rapidly acting insulin. Okay, once it is clear. So now come here, short acting insulin we are talking about means human insulin. So this human insulin, as far as the duration of the action is concerned, the duration of action is more than that of a duration of the action of a human aspart and a human lispro. And as far as the onset of the action is concerned, these two insulin, human aspart and human lispro, they act more quickly, or they start their action more faster than the human insulin. Okay, so we can compare in this way. And all these three insulin we are considering under short or rapid action category. Now we will move to the next category, that is intermediate acting insulin. So we have a NPH and a lente there. So these two insulin, NPH insulin and the lente insulin, they are intermediate acting insulin and they are available separately. Okay, so both these insulin they are available separately, whereas so this NPH insulin and the lente insulin, they are available here separately, and this protaminated aspart and protaminated lispro, they are not available separately, they are available only with the combination. Protaminated aspart and protaminated lispro, both the insulin, they are available in combination. So that's what I have mentioned here. See here, protaminated aspart and protaminated lispro, they are available in combination with the human aspart and human lispro. So here we have seen these two insulin, they are rapidly acting insulin, and this combination of a rapidly acting insulin with the intermediate acting insulin. Rapidly acting insulin, human lispro, with the intermediate acting insulin, protaminated lispro. Okay. So these two intermediate acting insulin, that is a protaminated aspart and protaminated lispro, they are not available separately, only in combination they are available, whereas this lente and this NPH, they are available separately. Now next one is a glargine insulin. Glargine insulin, which has been a long acting insulin here, and one more is there, that is what, ultra lente insulin. This ultra lente insulin is also considered as a long acting insulin. So this glargine and this ultra lente, they both are the long acting insulin. Now we will try to see some more information regarding these three categories: short or rapid acting, intermediate acting, and the long acting insulin. Now see this chart here. In this chart, as we have already discussed, this rapid acting insulin or a short acting insulin, intermediate and a long acting insulin, and also we will see the combinations of these insulin in a premixed category. So we have in a short acting insulin, we have just seen human insulin, or what we also call a regular insulin. So this human insulin lies with this short acting category, and if you see here, peak level is achieved in between 2 to 5 hours. So its peak level is between 2 to 5 hours, and its duration of action, very importantly, duration of the action is how much? 6 to 8 hours. What we have said just before few minutes, that this duration of the action of this short acting insulin is more than human lispro and a human aspart, isn't that? So see their duration of action here, 3 to 5 hours. That of a lispro and aspart, it has also got a same duration of the action, that is 3 to 5 hours again. Okay, so it is 3 to 5 hours versus 6 to 8 hours when we are comparing between this lispro and aspart with a human insulin there. This is point number 1. Okay, and if you see the onset of the action, what we have seen, the onset of the action of this rapidly acting insulin, they are more faster as far as onset of the action is concerned as compared to short acting insulin, that is a human insulin. So see here, onset of the action, what we have mentioned, inject 10 to 15 minutes before the meal time this rapid acting insulin, and inject at least 20 to 30 minutes before meal time as far as short acting insulin is concerned. And you can see here this difference is there. Why? Because they act very quickly, therefore they should be taken somewhere 10 minutes before the meal time, whereas this short acting insulin, that takes more time, that is human insulin, it takes more time, therefore it should be taken 20 minutes before this meal time. So if you see, if you compare in between these two, 10 versus 20 minutes, why? Basically because this human aspart and human lispro, their onset of action is more quicker as compared to short acting insulin, and therefore, so this is the difference, just what we have discussed a few minutes back, you can understand with this. Then let us come to now intermediate acting insulin. Okay, in the intermediate acting insulin, we have a NPH insulin and the lente insulin. Okay, and two things we have seen, which are those protaminated aspart and the protaminated lispro, but they are not available separately, therefore we will see them in the combination categories. So first see this NPH and lente, which are intermediate acting insulin. NPH is also called as a isophene insulin, we know that. See their duration of action, 18 to 24 hours, and lente again 18 to 24 hours. So duration of the action of this intermediate insulin is approximately 18 to 24 hours, and the peak levels, if you see, 4 to 12 and 3 to 10, so these are the peak levels of both these insulins. And these intermediate insulin, they are usually combined with this short acting insulin there, usually in with a combination. And also this remaining protaminated aspart and protaminated lispro, they are not available separately, as we had already discussed. They are always used with a combination. But these two insulin, they are available separately. Long acting insulin, in the long acting insulin, as we have just seen, this ultra lente and the glargine is there. This ultra lente, if you see, duration of the action is 20 to 36 hours. Ultra lente duration of action is more, whereas glargine insulin, the duration of action is 20 to 24 hours. So it is giving almost all the round of clock coverage as far as glargine is concerned, whereas ultra lente, it is acting more than that, 24 hours. Therefore, you have to give with the caution as far as ultralent is concerned. Now, we'll go for the pre-mixed combinations of the insulin. We have plenty of combinations is there with a different type of combination. See what options we have as far as combinations are concerned. Those options we will see first, and then we will go for the actual combinations. So, we will try to see those separately so that we can understand them better. Here we are talking about the combinations available in the market. This combination of a human insulin plus a NPH or what we call the isogen insulin is available in the market, and it is available in the combination of a 30-70 and a 50-50. So, when I say 30-70, 30% of this human insulin along with 70% of the NPH insulin, or when I say 50%, both these insulin they are available in the combination of 50% versus 50%. Okay. Then this human aspart is available with a protaminated aspart. Okay. Human aspart, we know it is a rapidly acting insulin. It is available with a protaminated aspart, which has been a intermediate acting insulin, and it is available with these three combination: 30% of a human aspart with 70% of a protaminated aspart, 50% of the human aspart with 50% of the protaminated aspart, and here 25% of the human aspart with 75% of the protaminated aspart. Now here this is the brand name human Nixtart, which is very famous one with this combination. Nomix is another brand name which is available in this combination, human aspart plus protaminated aspart. And one more, this human Lispro, it is combined with a protaminated Lispro insulin, and it is available with a 50-50 and a 25-75 combination there. Okay, 50% human Lispro with a 50% protaminated Lispro, whereas 25-70, 25% human Lispro with a 75% this protaminated Lispro. This is the brand name which is available with this combination there. Okay. So, this is regarding the combinations of the brands, those are available in the market. We can use them depending upon the situation, depending upon the patient's condition. We will try to gather some more information regarding the insulin. So, let us see. This human insulin is identical to the regular human insulin. Means what? This human insulin, it is a synthetic version of the naturally occurring insulin. This human insulin, it is a synthetic version of the naturally occurring insulin. It is similar to the naturally occurring insulin, that is the insulin that is produced in our body by the pancreatic beta cells. What about this aspart and a Lispro? We have just seen human aspart and the human Lispro. They are falling in the same category of a human insulin. This aspart, as I have mentioned, it is a human insulin analog or a genetically modified version. Okay, so this aspart insulin or a Lispro insulin, it is a genetically modified version of the human insulin. So, first of all, we have a naturally occurring insulin. and that we are making in the laboratory what we call as a synthetic insulin, and what is the name? Human insulin we have given, because it is similar to our naturally occurring insulin. So, human insulin, it is a synthetic version of our naturally occurring insulin. This human insulin we are genetically modifying, isn't that? This human insulin we are genetically modifying, and this modified version we called as a insulin aspart or a insulin lispro, or human aspart and a human lispro, which is a genetically modified version of the human insulin. So, once we know this, then we will go for the another thing, that is a protaminated aspart. What is protaminated aspart? It is again the same thing. This human aspart, what I have just told you, it is a genetically modified version of the human insulin. This human aspart, it is a protaminated, that is, it is linked here with a protein, protamine and zinc. So, it is getting protaminated. It is combined with so as to increase the absorption time. So, it is protaminated, means it is a protaminated aspart. And so also this lispro, human lispro, when it is protaminated, it is combined with a protein, protamine and zinc. It is a protaminated lispro. Okay. So, just like that, our human insulin, which we have just saw, which is identical to the naturally occurring insulin, it is also protaminated in the NPH form. NPH insulin, or this what we call the isophene insulin is what? It is a protaminated human insulin. It is a protaminated human insulin. So, let us try to see the same thing in a we will try to write these things separately. Now, see here, this human insulin, once it is protaminated, what we call it as a NPH or the isophene insulin. Human aspart, when it is protaminated, it is a protaminated aspart, and this human lispro, when it is protaminated, it is a protaminated Let's prove. So, what is this when we say protaminated? Means what? It is combined with a protein. Combined with a protein. Which protein? Protamine. Protamine. And additionally also we add a zinc. Okay. So zinc is also there. Okay. Now why we protaminate them? Why this insulin needs to be protaminated? Because we want this intermediate acting insulin. Now we have made this rapidly acting insulin. Once they are protaminated, they becomes intermediate acting. Their duration of action is increased. Once this rapidly or a short acting insulin they are protaminated, their duration of action is been increased. Once their duration is increased, then what we do? We use the combination of short acting or a rapidly acting insulin with a protaminated insulin. Okay. So we want some immediate coverage once the patient suppose this injection, this combination injection is given in the morning where before breakfast, then this rapidly or short acting insulin they will start their action immediately, isn't that? And suppose at about 9 a.m. This patient has taken this insulin or injected at this insulin and it is in the combination 30:70. Okay, it is in the combination 30:70 human mixed start is taken suppose, then this 30% portion, if it is a mixed start then it is containing this human insulin. This 30% portion will start its action immediately once patient because it is taken before breakfast. So after this injection patient is supposed to do his breakfast and the sugar which is going to be raised with this breakfast that will be controlled by this 30% portion. Now when this patient will take its lunch, suppose around about 1 p.m. then at 1 p.m. this protaminated part of this insulin is going to starts its action. So this 70% part which is initiating the action in a delayed manner after some period there, it is because it is getting slowly absorbed. Why we have an intermediate acting insulin? Basically because we want to use this in a single shot. Means what? We have given a single injection in the morning, the first part of this insulin which is going to act immediately, that will start its action within say 20-30 minutes, whatever the insulin we are using depending upon that. So it will start its action maybe 10 minutes, maybe 20 minutes. So once this action is started and it is taking care of our breakfast there, when we are taking our lunch, that the sugar which is raised because of its lunch is taken care by this intermediate acting insulin, isn't that? And because this insulin they are slowly being absorbed. Why they are slowly absorbed? Because they are protaminated now. Okay. So this 70% portion which is taking care of our lunch or which is taking care of the food of the glucose which is rising up because of our dinner also. So whatever the coverage we are getting, 18 to 24 hours coverage we are getting with the intermediate acting insulin is because they are slowly absorbed. When they given subcutaneously, they are slowly absorbed. And why they are slowly absorbed? Because they are protaminated. So, this protaminated insulin, this has been a very complex combination there, because it is a complex molecule. This protaminated, this NPH or this protaminated aspart or this protaminated lispro, this molecule is quite a complex one, and its size is quite larger than this insulin, this human aspart or human lispro, or even this human insulin, which is an synthetic insulin. All these insulin, the size of the molecule is small, where this protaminated, the size is large, as well as it has been a very complex molecule, and that is delaying the process of the absorption, and that is why this insulin becomes intermediate when it is protaminated. Okay. So, this is how we use the combination, this is why we do this protamination, and once they are put with this protamine protein, they become slowly absorbed, and they can act for 18 to 24 hours. So, this is regarding the combination. Just like the 30-70, as we have seen, there can be a 50-50 combinations, which are also been used quite popularly. So, depending upon patient, we decides the dose of the insulin. Now, here we will see general guidelines for starting oral hypoglycemic drugs in a patient with a type 2 DM. We will see these guidelines with 4 points: this lifestyle trial, early initiation, selection on the basis of the comorbidities, and if metformin is contraindicated. Look here, this initial management, with this initial management lifestyle trial, we choose when the blood sugar levels are less than 200 milligram, or more specifically if less than 180 milligram. Okay. So, if the blood sugar levels in the patient, you found that the levels are less than 180 milligram or somewhere 180 milligram, then you before going for this oral hypoglycemic drug, you should try with this lifestyle management. So, lifestyle management in the sense what? Diet and the exercise. Okay. So, then if suppose if the levels are more than 180 or more than 200, then what option you have? Then you should go for the early initiation of the oral hypoglycemic drug. Or this one more thing is there, the blood sugar levels may be more than 200, or if the patient is severely symptomatic. Okay. The various symptoms of diabetes, if they are present there, then again you may go for this early initiation. Metformin is universally preferred as the initial agent. Okay. So, this metformin, this drug should be your initial choice, provided there is no contraindication for the metformin. Okay. This basic contraindication is a diabetic ketoacidosis patient, you should not give it, or if the eGFR is less than 30, then also it is contraindicated. Otherwise, metformin should be your first choice. Now, this is metformin as a monotherapy, as a single drug. Now, when you should give a dual therapy or a combination of a two drug, when you should use a combination of the two drugs, meaning metformin, along with that you are giving one more drug there. So, this scenario could be there if this HbA1c level is more than 1.5 to 2% above the target. So, when the patient comes to you, you should always set one target in terms of HbA1c level, and if you feel that this patient's HbA1c, suppose this HbA1c of that patient is a 9, okay, 9%. Then you suppose your target is a 7.5% in that particular patient. Then how much is the difference? Difference is a 1.5%, okay. So the patient HbA1c level at that particular instant is 1.5% above the baseline or above your target. So in that condition you should go for the dual therapy, okay, combination of the two drugs. Then insulin is necessary if HbA1c is more than 10% or if the BSL is more than 300 milligram per deciliter, okay. So you should go for the insulin if the HbA1c is more than 10% or if the BSL is more than 300 milligram per deciliter. Now here regarding this dual therapy, this HbA1c it more than 1.5 to 2% above the target level. But basically, if suppose if you ask me tell us in terms of the percentage, then I will say if the HbA1c is more than or equal to 9%, then you should go for the dual therapy, okay. So dual therapy, if you want to start, HbA1c should be somewhere around 9 or more than 9%. If it is more than 10%, you have to go for the insulin, okay. So this is how we can decide. Then metformin is started with a minimum best possible dose and gradually increased over the time. So you decide to start a drug and you decide to start as a metformin as a monotherapy. Then here you should start with the best possible minimal drug. In the sense, suppose you have started with a 500 milligram OD, and then gradually over the period you can increase depending upon the sugar levels to 500 BID, if required 500 TID. Like that, you should increase the dose in the stepwise manner. Then metformin is contraindicated in a patient with a severe renal impairment. Okay, if the eGFR is less than 30, then you have to you should not prescribe metformin in that patient. Then selection on the basis of the comorbidities, meaning this atherosclerotic, ASCVD means atherosclerotic cardiovascular disease. These GLP-1 receptor agonist or SGLT2 inhibitors, they are preferred. Okay, so patient is coming to you, you want to start suppose dual drug therapy in that patient. And in that situation, along with metformin, suppose you want to add second drugs, then your choice should be and suppose if that patient is having a ischemic heart disease, then patient of a IHD and diabetes, the scenario is a IHD patient of a diabetes, along with that he has got ischemic heart disease also, and you want to give a dual drug therapy. In that scenario, your choice should be GLP-1 receptor agonist or these SGLT2 inhibitors. Why? Because these two categories of the drugs, they are cardioprotective. Okay, so this two categories of drug we are choosing on the basis of the comorbidity. So along with diabetes, the patient has got comorbidity in terms of ischemic heart disease, and your option should be this GLP-1 receptor agonist or SGLT2 inhibitor. Then if the metformin is contraindicated, then you have the option of these sulfonylureas, DP4 inhibitors, SGLT2 inhibitors and alpha glucosidase inhibitors. If the metformin is contraindicated, these sulfonylureas there is a risk of the hypoglycemia and the weight gain. Okay, so if already the patient is obese, or if you feel that the patient is having a greater risk of the hypoglycemia, then you should not choose these sulfonylureas. DP4 inhibitors, they have got low risk of hypoglycemia. Okay, so they can be safe in that patient, and also more importantly they are weight neutral. So here suppose the patient is obese, there you cannot give sulfonylurea because there could be a weight gain there. So if the patient is obese, and also if in the same patient if you feel that there can be a risk of hypoglycemia there, then your choice should not be the sulfonylurea. Rather, in that patient where the patient is obese or where there is a chances of this high risk of hypoglycemia, then your choice should be this DP4 inhibitors, because they are weight neutral as well as there is a low risk of the hypoglycemia. Then SGLT2 inhibitors, they can cause this weight loss and offers this cardiovascular protection. Okay, so in a patient where there is a comorbidity like ischemic heart disease, if it is present, then you can go for the SGLT2 inhibitors into those patients if this metformin is contraindicated. Then alpha glucosidase inhibitors useful for targeting postprandial glucose spike. Okay, so in many patients we do see that the postprandial spikes are there, and these alpha glucosidase inhibitor, they slows down the absorption of the glucose, and they prevents the sudden rise in the glucose level in the postprandial period. Therefore, in those patients where we are getting postprandial spikes, we can use alpha glucosidase inhibitors in those patients. So, we have gone through the very important aspects as far as the general guidelines are concerned, and while starting the dose, while adding another drugs, or when you are talking of when you have patient with some comorbidities, these things you should always remember in your mind when you are prescribing these drugs. Now here we will see the monitoring and the adjustment in a patient who is a diabetic and he is on the oral hypoglycemic drugs. So look here, frequency, glycemic control should be assessed. Okay, so we know that we should make a periodic assessment of the blood sugar. So patient is having a diabetes who have started oral hypoglycemic drug, and we want to make a periodic assessment how much the blood sugar are controlled. So in that sense, we may initially the periodic assessment may be say 2 weekly, 15 days, 1 monthly periodic assessment may be needed. And once we achieve a particular target, then we may just make the periodic assessment quarterly, or even twice in a year, likewise that. Okay, so the important thing is we should make a periodic assessment of the blood sugar. Initially this periodic assessment should be done twice in a month, or once in a month, and once we achieve a specific target, then this periodic assessment may be declined to thrice in a year or twice in a year, like that. Then dose escalations. Typically these dosages are increased with small increments over the time. Okay, so when we want to increase the dose in this patient, we should increase the dose in a stepwise manner. So we are making a periodic assessment, and when we found that this blood sugar level still needs to be controlled, then we increase the dose. Okay, over the time, until the target is reached or the maximum advisable dose is achieved. So when we are increasing the dose, two things are there. First one, what is our target? Okay, what is the target we want to achieve in that patient? What is the target blood sugar level we are keeping in our mind, or what is the targeted HbA1c levels we want to achieve? Depending upon that, we have to increase the dose or the maximum advisable dose, or also we should keep in mind what is the maximum dose advised with that particular drug. Okay, so if we have achieved a particular target, suppose the patient is on the OHD and we have achieved a particular target, that is below suppose 180 milligram per deciliter of the blood, then we can stop with that particular dose. Suppose there will be a scenario when the blood sugar levels are still not under control and we have gone to the maximum advisable dose, then in that scenario you have to add one more drug there, you have to change your strategy. Okay, so dose escalations, you are supposed to increase the dose over the time depending upon the target and depending upon the maximum advisable dose. Then target HbA1c, what is that? The target A1c is usually set for most adults. Okay, so when you are treating a patient, you should set up a goal there, and a goal in terms of a HbA1c level. Okay, so when we are setting the goal, we should keep in our mind age and the hypoglycemia risk. Meaning what? Suppose the patient whom you are treating is a young one, okay, say around about 35 years of age. In that patient, your aim should be a very strict control. In other words, you should keep in your mind a target of a HbA1c level in between 6.5 to 7. And the individual, suppose there is another individual with age say around about 65 to 70 years of age, in that patient your target HbA1c need not to be this very strict one, rather you may choose 7 plus or even 7.5 HbA1c may choose in that particular individual. Okay, so the point is in younger patient, your HbA1c target should be very strict, whereas in older patient, you can just release that target to some higher levels up to even 7.5 or sometimes maybe 7.6 or 7.7 like that. Okay, in a older patient. Okay, because in those patients the risk of hypoglycemia is more, whereas in younger patient what we want with younger age we do not. Now why we are setting a target? Because basically we want to minimize the complications with the diabetes, like diabetic neuropathy, diabetic nephropathy, and therefore in a younger patient where the life expectancy is more, in those patients our target should be very strict, whereas older patient we can just remain flexible with our targets. So these points are very important in terms of monitoring and adjustments. Okay, thank you. Now here we will see the availability and the administration of various oral hypoglycemic drugs. We'll start with this sulfonylureas, and I have just mentioned that here three various molecules which falls in the category of this sulfonylurea. So let us start. This glimepiride, it is available as a 1 milligram, 2 milligram and the 4 milligram tablets, and we can take it once daily or twice daily, and with breakfast or with meal. Suppose if we are decided that we will take it once daily, then the option is we may take that with a breakfast or we may take it with a meal. If we are giving twice daily, in that scenario we may take a first dose with a breakfast or with a lunch, and second dose with a dinner. Then this one more thing is there with glimepiride, that this 0.5 milligram strength is also been available, and usually we give that with a metformin, And this strength we use in a patient where we feel that there is a chances of developing a hypoglycemia. So we may use as low dose as this 0.5 milligram of glimepiride in these patients. Then glycoside, it is available as 2.5 milligram to 10 milligram. So 2.5 milligram is available, also 5 milligram and 10 milligram options we have, and we take it as a single dose or the divided dosage, and we take this drug 30 minutes before food. Then next is a glycoside. This glycoside, it is available as a 40 and 80 milligram tablet, that we take with a meal, and also it is available as 30 and the 60 milligram extended release tablet also. This one more thing regarding this extended release tablet is they should not be chewed or crushed. Otherwise, the basic thing what we want is extended release, so that effect may goes away. So this glycoside we may take as a 40, we may choose as a 40 or 80 milligram, or we may choose as a extended release tablet of a 30 or a 60 milligram. If this extended release tablet we are taking, it should not be crushed or chewed. Otherwise, this effect of extended release we may not get it as we wanted. Then next is this metformin. We know that this metformin basically, once the diabetes is detected for the first time, if it is not contraindicated, your drug of choice should be metformin. And this metformin the available as of 500 to 1000 milligram tablets, even 250 is available. Basically 500 to 1000 milligram tablet once or twice daily we can give. Then alpha glucosidase inhibitor, they are available as a 25, 50 as well as 100 milligram tablets, and we use this 3 times daily before meals. Then pioglitazone, it is available as 15, 30 and 45 milligram tablets once daily with or without food. This pioglitazone nowadays we do not use because its side effects. DPP4 inhibitors, we have 3 options here, linagliptin, sitagliptin and the vildagliptin. This linagliptin, it is available as a 5 milligram tablet to be taken daily. Then sitagliptin, it is available as 25, 50 and 100 milligram. These 3 strains we have to be taken once daily. And this vildagliptin 50 milligram if once or twice daily. And this 100 milligram extended relief tablet is also available, which can be taken once daily. Then next is this SGLT2 inhibitors. This SGLT2 inhibitors, 3 drugs we have, canagliflozin, dapagliflozin and this empagliflozin. Of this canagliflozin, it is initially we give as a 100 milligram tablet daily, and gradually the dose may be increased up to 300 milligram, okay, daily. So initial starting dose is 100 milligram daily, and gradually we may increase up to 300 milligram daily. This dapagliflozin, these 2 strengths are there, 5 and 10 milligram, and it is to be taken once daily. Then empagliflozin, it is available as 10 milligram or 25 milligram, which is to be taken once daily. So and this is regarding the availability and the administration of these various oral hypoglycemic drugs. Now we will see one more category of drug, what we call as a incretin mimetics or GLP-1 receptor agonist. We know that these naturally produced hormones by our body by the endocrine cells. These hormones they acts on the receptors. So there is a receptor for these naturally produced incretins, and these incretins are secreted by our enteroendocrine cells, and these enteroendocrine cells are present in the intestinal wall there, and these naturally produced hormones by these cells, GLP-1 and GIP, they acts on which cells? Pancreatic beta cells. They have the receptors over the pancreatic beta cells. They combines with this receptor and they catalyze the process of insulin secretion. So we knows this. We have a drug which we call as the incretin mimetic drugs. So these the molecules in these drugs, these incretin the incretin molecules in this drug, which acts as our naturally produced incretins. So in other words, we have here a synthetically formed incretin molecule here, and this synthetic incretin molecule is going to boost or going to catalyze the process of insulin secretion. And in this category we have so many drugs, but this semaglutide, liraglutide and this dulaglutide, and one more is there what we call exenatide. So these 4 drugs are there in this category, and of these 4 drugs, this semaglutide especially we can use for one another purpose other than type 2 diabetes, and that is weight loss. Okay, so for the purpose of the weight loss also we can use a semaglutide also. But this drug can be used in both way, for in a type 2 DM as well as in a weight loss patient. Here we will try to see some more information regarding this semaglutide in terms of a diabetes only. As far as weight loss is concerned, that we will not considering at the moment, just we will go for with the diabetes. So see here. So this semaglutide, its initial dose is 3 milligram once a day. Now regarding this semaglutide, it is available orally as well as in the injectable form. We can give it orally as well as it is available in the injectable form also. And this oral dose of this drug, initial oral dose of this drug is 3 milligram once a day, and we have to continue it like for say 1 month, and we have to increase the dose after 1 month from 3 milligram to 7 milligram. Okay, so dose increase from 3 to 7 milligram after 1 month, and if at all we want to increase the dose after that, so that we can do after another 1 month. So if we want to achieve the dose from 3 milligram to 14 milligram, it takes almost 2 months there. Okay, so initiation of the therapy with 3 milligram per day, we have to continue like that for 1 month, and after 1 month we can start with 7 milligram per day, and that we have to continue for 1 month, and after 1 month still if you want to increase the dose, then we can do that after that completion of 1 month period there to the 14 milligram per day. So this is what the dosage schedule with this, and the maintenance dose actually this drug 7 to 14 milligram once a day. This is the maintenance dose with this drug. Now if at all we want to give subcutaneously, then what are the options here? When we are giving it subcutaneously, we have to start with a 0.25 milligram subcutaneously once a week, very importantly once a week. Okay, so this injectable form which is available, semaglutide, this injectable form is available, and this injectable form we can use once a week, and that has to be given subcutaneously. So When we are giving it subcutaneously, what is the dose? 0.25 milligram. It is the initial dose. Okay, I am giving more stress on what? Initial dose. Okay, we'll see that why I am saying like that. So when we are giving orally, the initial dose is a 3 milligram, and when we are giving subcutaneously, the initial dose is a 0.25 milligram subcutaneously, and when we are giving orally, the initial dose is a 3 milligram. So 3 milligram is the initial dose for this semaglutide when we are giving orally, and 0.25 milligram subcutaneously. This is the injectable form of semaglutide, and this is the initial dose 0.25 milligram. And if we want to increase, rather we have to increase dose. So we needs to increase the dose from 0.25 milligram to 0.5 milligram, but that we have to do after 4 weeks. Now we are taking how much dose? 0.25 milligram once a week, and we have to continue it for 4 weeks. Means what? We have to take 4 dosages when we are initiating the therapy with 0.25 milligram subcutaneously, 4 dosages. And once we complete these 4 dosages, then we have to shift the patient to 0.5 milligram. Okay, so after 4 weeks or after 4 dosages, like once in a week, we have to shift the patient to 0.5 milligram subcutaneously once a week again. Okay, once a week for another 4 weeks, and after 4 weeks, like that, if you want to increase the dose, if the sugar you feel that you have to increase the dose, then at that moment you can go for 1 milligram subcutaneously. So the maintenance dose is how much? 0.5 to 1 milligram once a week, and this 1 milligram is the maximum dose. Likewise, as far as oral is concerned, 14 milligram per day is the maximum dose. Now let us see here. Now this is the switching schedule. Anybody who is receiving oral tablets, then what is the parallel dose for that patient when we are if you want to put him on a injection? Then see, anybody is taking 14 milligram orally, then the parallel dose is a 0.5 milligram subcutaneously. Okay, so anybody is taking 14 milligram orally, and if you want to shift that patient to the injectable form, in that scenario the parallel dose is 0.5 milligram subcutaneously. Likewise, if anybody is taking 0.5 milligram subcutaneously, and if you want to put him on a oral form of this semaglutide, then the option is 7 to 14 milligram orally. Okay, so this is what we should do as far as this transition is concerned. See here, this dosage of 0.25 milligram subcutaneously once a week and 3 milligram orally once a day are intended for the treatment initiation only. So these dosages, that is 0.25 milligram in the injectable form and 3 milligram in the oral form, they are only for the purpose of the initiation of the therapy. They do not have any significant effect as far as the glycemic control is concerned. So they are only for the purpose of the initiation. The real dosages are 0.5 milligram and 1 milligram in the injectable form subcutaneously, and 7 and 14 milligram in the oral form. So that's all with this drug semaglutide in a type 2 DM. Now here we will see this adverse effects with the various categories of these oral hypoglycemic drugs. Let us start with the metformin. This metformin, these side effects, this diarrhea is almost occur in 12 to 53% of the patient, whereas this nausea and vomiting, it is contributing 7 to 26%. So these the diarrhea, nausea and vomiting, they are making a bulk of the contribution in terms of the side effects with the metformin. Then next is a sulfonylureas. We may get a syncope with the sulfonylurea, but the percentage wise it can occur in less than 3% of the patient. Then dizziness in 2 to 7% of the patient, and this nervousness, anxiety and the depression, it is contributing somewhere in between 3 to 4%. Then thiazolidinediones, these may cause edema in 27% of the patient, and hypoglycemia again in 27% of the patient, whereas heart failure in the 8% of the patient. So this edema and the hypoglycemia, their contribution is quite high there in terms of side effects. This because of these side effects, this edema there, usually in a patient of a heart failure, we usually should avoid this drug. And nowadays, with the availability of this better oral hypoglycemic, the use of this category of drugs is also been getting reduced. Now we'll move to the next, that is alpha glucosidase inhibitor. This alpha glucosidase inhibitor, usually if you see the side effects of a flatulence and a diarrhea, they are contributing to a maximum in terms of a side effect. This flatulence we can get in almost 74% of the patient, with diarrhea in 31% of the patient, and also this abdominal pain in 19% of the patient. Then next category of drug, that is a DPP4 inhibitors. This sitagliptin of this category, if you see here, this nasopharyngitis in 5% of the patient, and other side effects like this raised creatinine, this acute pancreatitis, acute renal failure we may get, and regarding this hypoglycemia, only in 1% of the patient. Then sexagliptin, it is causing this peripheral edema in 4% of the patient, headache in 7% of the patient, UTI in 7% of the patient, and hypoglycemia in the 6% of the patient. So these side effects, this peripheral edema, headache, UTI and hypoglycemia, this for this we should watch in this patient if you are prescribing these drugs. Then linagliptin, it can cause increase in the serum lipase in almost 8% of the patient, increase the uric acid with 3%, and this nasopharyngitis, acute pancreatitis and hypoglycemia, it can also cause. So overall, if you see these side effects, we should keep in mind when we are prescribing these drugs, and we should also see that in a patient, suppose this linagliptin, if this uric acid is it is causing raised uric acid, so we should avoid it in a patient of a gout. So this thing we should keep in mind when we are prescribing these drugs. Then SGLT2 inhibitor, this regarding their side effect, if you see this nausea, this fungal vaginosis and this bone fractures, they are contributing, each of them is contributing almost 8%, and this urine tract infection in almost 6% of the patient with a SGLT2 inhibitor. So these are the various adverse effect we get with the various categories of the drugs we use in a patient of a diabetes. Here we will see the contraindications with various OHD categories or with the specific drugs also. So see here, this metformin it is contraindicated if this eGFR is less than 30. Okay, so in a severe renal dysfunction where the eGFR is less than 30, it is contraindicated. As well, it is contraindicated with the metabolic acidosis, including diabetic ketoacidosis also. So, this metformin, it is contraindicated with the metabolic acidosis, including that of a diabetic ketoacidosis. Then this sulfonylureas, usually we should not use these drugs with hypersensitivity to drugs or the sulfonamide. We should not use this drug. And also in a diabetic ketoacidosis, TK meaning diabetic ketoacidosis. Now this hypersensitivity is applied to each and every category there. Okay. Pioglitazone, we should not use this drug, this pioglitazone, if the dyspnea is in the range of New York Heart Association class 3 and a class 4 type of heart failures. Okay. In those patients, NYHA class 3 and the class 4 heart failure, we should not use this drug. Then one more contraindication with this pioglitazone is a CA bladder, and also this serious hepatic impairment, we should not use this drug. Then next is a alpha glucosidase inhibitor. It is contraindicated with diabetic ketoacidosis, then cirrhosis, then inflammatory bowel disease, these intestinal ulcers and the intestinal obstruction. All these diseases or conditions, they are the contraindications for these alpha glucosidase inhibitor. Then this SGLT2 inhibitor, it is contraindicated with the ESRD, that is end stage renal disease, and a patient on the dialysis. Then the DPP4 inhibitors, of this DPP4 inhibitor, we know that we have seen these three drugs, hexagliptin, sitagliptin and linagliptin. So these two drugs, they need dose adjustment in a patient with a renal failure, hexagliptin and sitagliptin, whereas this linagliptin, if you are using in a patient of renal failure, you can use without any dose adjustment. So that has been a very important thing we should know. So in a patient of a renal failure, without any dose adjustment, we can prescribe this linagliptin. So while prescribing these oral hyperglycemic drugs, you should know these specific contraindications.